ablation procedure, about 9% of those paroxysmal AF patients progress to persistent AFib just waiting for their ablation to happen. Importantly, though, once you did their PVI, and this was a PVI alone trial, 81% of them regressed back to paroxysmal AFib. So you were able to turn the clock back. So if persistent AFib has higher rates of stroke, higher rates of death, higher rates of heart failure hospitalization, by putting them back into paroxysmal AFib, you potentially lower all of those rates. And then just the last piece here is, again, going back to CAPLA. So CAPLA is a trial of persistent AFib. And if you look at what happened in CAPLA, the majority of patients with persistent AFib had no recurrence. But of those that had recurrence, the majority were paroxysmal. So in this trial of ablation for persistent AFib, the majority of recurrences were for paroxysmal AFib. So you turn persistent AFib back to paroxysmal AFib. And then if you look at the healthcare utilization there in those bar graphs, you see that the dark blue, so paroxysmal AFib, much lower rates of hospitalization, much lower rates of cardioversion, and lower rates of repeat ablation compared to those that recurred with persistent AFib. So again, if we view that atrial fibrillation as a chronic and progressive disease, and we think that catheter ablation has the ability to impact that progression in the disease, by intervening sooner, we can actually revert people back to earlier on the curve, and that earlier form of disease has less healthcare utilization, better quality of life, and lower risk of major complications. And so to summarize, we know that persistent atrial fibrillation is a higher risk group compared to other atrial fibrillation cohorts. We know that ablation is more effective at preventing recurrences, improving quality of life, and reducing healthcare utilization, which are basically the three things that we care about most with a treatment of atrial fibrillation. We know that the procedures that we do are safe and are effective, and by doing them earlier, we know that it's going to give us the greatest opportunity to improve outcomes. Thank you.
So it's my pleasure to invite Dr. Jonathan Kalman from Parkville, Australia, to come up with the arguments against.
Okay. Good morning, and that's certainly difficult to follow. But I'm not here to convince you that when patients have high burden atrial fibrillation that we ought to be treating them with antiarrhythmic drugs. Instead, I'm going to focus a little bit more on the early aspect and the timing. These are my disclosures. So, as Jason did, I'm going to broaden the scope a little bit because we know that 60% of persistent atrial fibrillation, at least in some series higher, is transitional from paroxysmal. We know that patients go through phases of having both paroxysms and persistent episodes. And much of the evidence we look at is a bit of a mixture. And so I think it's really important to look at the broad sweep of what's happening when we talk about timing and early. But as Jason said, let's take the consensus statement and the highlighted statement: catheter ablation of AF may be reasonable as first-line treatment in symptomatic patients with persistent AF. Area of uncertainty based on opinion only. We have no evidence for first-line ablation in persistent atrial fibrillation. So where does the rush come from? Where does the hurry come from? And as Jason has indicated, it comes from the diagnosis to ablation time data, this concept that's arisen in our field. And here I put up a meta-analysis of 6 studies. And what these studies say to you, if you delay by 12 months from the first diagnosis, you have an almost 30% reduction in ablation efficacy. Pretty dramatic if it's correct. If we look at these studies, however, when you look across the quartiles, the patient populations are fundamentally different. The early quartiles are younger, they have less risk factors: hypertension, heart failure, coronary disease, lower CHA2DS2-VASc. Very difficult to ascribe causation. And then some of the data from these studies, and there are many of them, are somewhat confusing because they're sort of inconsistent with each other. On the left, we have a registry study, large registry study, that says that if you don't get it done in the first 12 months from diagnosis, you lose 20% plus efficacy. But after that, it doesn't matter if it's a year and a half or 10 years, no difference. it really doesn't gel with anything that I know about progression of atrial remodeling. On the other hand, this large database analysis, over 11,000 patients, concluded that the adjusted risk of AF recurrence increases by 20% for each year of DAT, and it's linear, and there's no threshold. It starts at the point of diagnosis and continues unabated. So very dramatic. So we looked at this in the Kaplan database, which is a prospective study, well-curated population, standardized entry criteria. That's important, we'll come back to that. Prospective follow-up, daily ECG monitoring. We saw a signal, but not the 20% to 30% that people are talking about, rather 2.5% annually that didn't quite reach statistical significance. But if you compare Q1 with Q4, there was differences. And the important data, the improvement in quality of life across the board, held up. So these are patients who did very well despite having very long DAT and no worse than those with short DAT. Indeed, we subtitled this "Any Time Can Be a Good Time to Ablate" based on these results. And the other interesting thing we found was that the remodeling, atrial remodeling, Q1 versus Q4 did not differ. And we would say that's because of the variable natural history to get to the same point. The diagnosis to ablation time is fundamentally flawed. It fails to incorporate all of these critical factors: symptom severity, patient preferences, burden, rates of progression. We'll talk about remodeling shortly. I'm not sure that DAT can be accurately measured. You've all had the experience sitting in your office with a patient and their first AF diagnosis is 3 months ago. You have the ECG, but the patient says to you, "Doctor, I've had this for at least 2 years." And the patient's partner turns to the patient and says, "No, dear, you've had it for at least 5. So which number do you write down? But the most important factor here, the most important thing missing from the DAT studies are all of those patients doing well without an ablation. And so it's a very, very biased group of patients. So when we talk about the natural history of atrial fibrillation and patients who do well over a long period of time, this is a meta-analysis, 47 studies, overall phenotype progression, about 8% per year, a bit more in persistent, a bit less in paroxysmal, but non-linear, and marked heterogeneity within and between studies. The drivers of progression, risk factors, age, hypertension, heart failure, but interestingly, the most significant association with the differences is the duration of follow-up. Studies that had over 20 years of follow-up had progression rates of 4% per year or lower. You could see the whole sweep of the natural history. So AF progression is not inevitable. And Jason showed us that in this landmark study. If we're talking about progression, really important loop recorder study, first-line ablation. Absolute difference at 3 years, 5%. So what's that saying to me is, depending on symptoms, but not worrying so much about progression, you can relax a little bit. And let's look at the patient population in this series. Median time to diagnosis a year and up to 3 or 4. The DAT studies are saying that's too late. It's all over. Symptoms, 3, median number of symptomatic episodes per month, 3 and up to 10. So that's a really symptomatic group. That's a group that's getting ablation in our lab every day of the week, I'm sure in yours also. But the question you're asking is, well, this is first-line ablation. How does a patient go 1 to 3 years with that burden of AF and no one has even offered them an antiarrhythmic? And the answer is that for most of that period, they did not have that level of symptom burden. They were much less symptomatic. And then they reached a progression point at which the treatment received was entirely appropriate. So first-line ablation doesn't mean first-time ablation, and that's important. This is another loop recorder natural history study. 417 patients from the Netherlands, mean duration of AF at the time that they entered the study, 2.5 years. In the next 2.2 years, 11% had no AF. Over 3/4 had no progression of AF, and of that group, 318 patients, only 10 went on to have a pulmonary vein isolation in that follow-up period. So they're all doing well. And of course there was a group that progressed, and no one for a moment is suggesting we leave those patients alone, or at least I'm not suggesting that one continues to struggle with antiarrhythmic agents that aren't working. The early ablaters will say to us, look, you've got to start right at the beginning or it's going to be too late. It's the ablation that's going to change the natural history, but ignore the fact that there's these risk factors that lead to the first episode, that lead to an episode that occurs after no AF has happened in the past year. So those risk factors that progress the remodelling are critical in this discussion. And we know from the Adelaide group, Reverse AF, that for patients with paroxysmal atrial fibrillation who adhered to risk factor management, lost weight, maintained weight loss, very few progressed. And in more good news, if you had persistent AF and you adhered to risk factor management with sustained weight loss, then a very large percentage had regression from persistent to paroxysmal or to no AF. Now, again, if we have a patient with high burden AF and multiple risk factors, we will pursue both ablation and risk factor management. AF itself, of course, progresses remodelling. And these are data from our own group. It's an observational study showing that markers of mechanical and electrical function progress. Remodelling progresses with medical therapy and regresses following ablation. What we didn't do in this study was ask this question: what would happen with delayed ablation to the remodelling? But what we did show was that you needed 10% burden or more to have progressive remodelling. Less than 10% remodelling, no progression less than 10% burden rather, no progression of remodelling. So low burden, infrequent atrial fibrillation does not appear to be driving the process. We did do this randomised study, and it's a study that patients referred to us for management. We randomised them either to maximised medical therapy for 12 months and then ablation, or early ablation, and we looked and compared the groups 12 months post-ablation, mixture of paroxysmal and persistent almost evenly split. And what we found was time to recurrence, no difference. Absolutely superimposed curves. And importantly, both groups derived the same improvement in quality of life. So you do have some time to talk to your patients about what their preferences are without having to feel this urgent push to ablation. If we look at the burden data, median burden, delayed ablation, 0, held up in both paroxysmal and persistent groups. Now, what about outcomes? And these data are very well known to us. This is the East AFNet data that showed that rhythm management matters, and it matters for a primary outcome that includes cardiovascular mortality, stroke, heart failure, hospitalizations. But the majority of those patients were managed medically. Ablation in just 8% to enter and 19% at 2 years. We have no good randomized data that says that if you don't intervene early, your patient is going to have further adverse events. The accompanying editorial, good rhythm control without haste. AF ablation remains effective after a year of, Andreas and Pallas didn't mean waiting, they meant active medical rhythm control. No one is saying let these people go. Many of them won't require medical treatment, just careful follow-up. I'd like to finish with this slide and then probably one more slide from what would have been the rebuttal, and that's this concept, the concept of the AF progression point rather than the time of diagnosis, progression point to ablation time. And it's not my concept. Many people have talked about this. If you look at the middle section, the histogram over a 5-year follow-up, it's an example of a patient who's diagnosed and then has rapid progression to high burden atrial fibrillation. Progressive remodelling with that gets an early ablation. In the next line down, you have a patient that goes over 3 years with minimal episodes of AF, just as we saw in the Netherlands study, and then starts to progress, and then gets progressive remodeling and an ablation at that point. But those two patients, the early and the delayed in this schema, reach the same point, have the same amount of remodeling and the same types of outcomes. Like many of the patients in the early AF trial, and certainly in Kaplan. But then you come to the top line, and there's a patient still doing well 5 years later. On the day I left Melbourne to fly here, and I can't remember what day of the week that was, I saw two such patients who'd had AF for 4 or 5 years, seeing them annually, asked them the question, do you want an ablation? No. No progression of remodeling, doing well. I would argue that indeed in the retrospective studies, the diagnosis to ablation time is probably the point of progression of AF, because in those series where you're dredging through looking for ECGs, most of those patients get their ECGs when they start to have more frequent episodes. And you'd say, well, okay, the concept holds up, but here's the problem. The problem is in the era we live and work, patients are coming to us now literally with their first episode of AF or second episode of AF because we live in the era of the wearables. And if you accept that the clock is ticking from the first episode, a lot of these patients are going to get an ablation that they may not need for years, if at all. So I don't know if I can get to my last rebuttal slide. It seems not. I was going to just say something about where we agree and I guess what we're arguing about to an extent. And much of, I think, what Jason spoke about were those patients with high burden atrial fibrillation. I think there we're on the same page. The patients that I'm primarily talking about are those, and remember from the Netherlands data, 85 to 90% of the patients in that study, low burden, non-progressive. Thank you very much.
Thank you, Jonathan. Next speaker is Melanie Gana-Guardin from Hamburg, and she will be discussing these two talks. Melanie, please.
Thank you very much. Strong debates, and I'm happy that I can maybe fuel the discussion a bit further. So the evidence is striking. Persistent atrial fibrillation is a disease that we need to avoid from occurring. And it's not only the type of AF, but especially the progression to it, because it's associated with clinical endpoints, such as stroke, hospitalizations, and worsening of heart failure. This has been shown, for example, in the CHART-2 study that has recently been published in patients with HFpEF. But I also want to say that the immediate link between treatment and with rhythm control and avoiding those outcomes is yet not evident for all patients with persistent atrial fibrillation. So Jason Andrade showed us that catheter ablation in persistent atrial fibrillation leads to less AF recurrence, improvement in quality of life, reduced healthcare utilizations, and he showed that the complication rate is now low with new technologies and improvement of the procedure. However, there still might be life-threatening complications on the day of the procedure. John Kalman taught us that the EAST study did not fail, although 20% did only received an ablation. So the majority of those patients were treated with drugs and medication. However, there has been a study shown with 770,000 patients with new onset atrial fibrillation, and 142,000 of them received antiarrhythmic drugs. And it was associated with a twofold and fivefold increased risk for syncopes and pacemaker implantations. So is it really an option for all our patients? And also, John Kalman challenged the definition of first and early with the diagnosis to ablation time. What exactly is early, and what does it clinically mean? And when we talk about first in the topic title of this discussion, do we talk about first diagnosis, first episode, or first as in first line, as in strategy? There has been a link between new onset atrial fibrillation and a higher risk of death and other events, so this is something to consider. And how much time can pass until we undergo rhythm control? Reasonable diagnosis to ablation time seemed not translatable to higher AF burden or symptoms in the Kaplan sub-study to persistent atrial fibrillation patient, which John Kalman showed. It showed that the cutoff was made at 67 months. Why change the strategy then? And what is the other solution? Is it really medication instead of ablation? And what is really reasonable when we talk about diagnosis of ablation time, when Jason Andrade just showed us that there's a clear association between diagnosis of ablation time and AF recurrence that has no lower limit. So the shorter, the earlier, the better. But the discussion is even more complex because if we are really truly honest, both rhythm control strategies, ablation and antiarrhythmic drugs, have limits in this cohort of persistent atrial fibrillation patients and might be not efficient. So I raised the question to the two of you, what is the right persistent atrial fibrillation patient for rhythm control per se? And what do we look at as clinicians? Is it symptoms, left atrial size, age, weight, comorbidities? And which comes first? Is it risk factor management? Is it medication, ablation for which patient? The combination of those strategies is often necessary to maintain sinus rhythm. And how do we even define persistent atrial fibrillation best? And this is what John Kalman ended with, that at the end it really comes down to an individual approach that is hard to test in a clinical study. And lastly, in this little talk of mine, I want to just say that the yesterday published ESC guidelines don't really give us a hint. They say it is not clear whether first-line ablation is superior to drug therapy in persistent atrial fibrillation. And also, just to finish this, I want to read you a little sentence I read in the guidelines that have been published yesterday, and I would like to put this into discussion. It says, antiarrhythmic drugs do not eliminate recurrence of AF, but in patients with paroxysmal or persistent AF, a recurrence is not equivalent to treatment failure if episodes are less frequent, briefer, or less symptomatic. So what is our goal of rhythm control after this? Is it complete elimination of AF or just less symptoms? So I would ask the two of you for your opinions and rebuttals on each other's discussion, please.
Thank you, Melanie. Thank you. So we still have some minutes for discussion. So please, if you have any question that you would like to address to the speakers, go to the microphone. In the meantime, maybe I can start asking you, for example, Jason, you mentioned that contemporary ablation is safer than drugs. But what does it mean contemporary? Because contemporary means nowadays. But if I would be a patient with a single persistent episode, I will be concerned for the future contemporary. And maybe in the future that we even something safer than PFA, so maybe I will be tempted to wait for that reason. So it's not only about quality of life, this is also a question that often patients ask you when they attend the clinic. So what is your opinion on this?
So, I don't know if, there we go. The paper that I showed is in the largely pre-PFA studies, because it ended in 2022. So it was mostly what you were seeing was contact force RF versus non-contact force, or the early contact force studies. And then basically Medtronic cryoballoon, because that was the only other alternative. Very small amounts of other technologies like the endoscopic laser. So in the pre-PFA era, ablation, I would argue, has become safer and the complication rates are low. I can't say what it is in the PFA era because we're not quite there yet with the studies, and Advent would suggest it's no worse. There's always the question around early adopter versus waiting for the next best thing. I think that in the view that, AF will progress, what do you lose by waiting versus what do you gain by going now with theoretically an inferior technology to something that may come that's better? I would say that if you're at the point where your AF is intrusive and symptomatic and your healthcare utilization is starting to climb, now is the time to intervene, right? And John highlighted this, as that was the design for early AF. It was not first presentation, it was not first diagnosis. It was you were at the point where your AF was problematic and intrusive. we needed to provide you with your first treatment, and what should that treatment be? That was a paroxysmal population. Avant-Garde, which is an ongoing study, will tell us the same question for persistent AFib. So using Farapulse versus drugs with loop recorders in place. So, hopefully in a couple of years, we'll get the answer for persistent AFib and be able to say. But as of right now, I would argue that what we know is drugs don't work better or worse compared to ablation in a persistent population. If you're highly symptomatic with your persistent AFib and you need an intervention, it's entirely reasonable to pursue a first-line ablation based on opinion, but it is not the be-all and the end-all. It is in partnership with lifestyle modification, risk factor optimization, and basically substrate modification through non-ablative terms.
Thank you. There's one question there. So please identify yourself.
Good morning. My name is Yazan Mosen. I'm from Cologne, Germany. So thank you for the talks. My question is regarding the artery remodeling and possible ways to stratify these patients. So it seems from your talks that artery remodeling is the decisive factor for the efficacy of the ablation. And are there any current works that looking into stratifying the patients by looking into atrial cardiomyopathy with LG-MRI or with atrial strains or other deep learning methodologies? Or do you think that would be something that we should concentrate on?
Yeah, I think that the way we evaluate remodeling, is probably, particularly non-invasively, is probably quite rudimentary. You talk about strain, MRI scar. Not all of us have been able to reproduce those data. Non-invasive electrical approaches are fairly gross compared with endocardial approaches. So I think there is probably a great opportunity and simple atrial enlargement and atrial strain, and maybe some measurements of the P wave. So I think there is a lot of scope for us to understand.
Do you see the point of performing an MRI in a patient who's presenting with AF and see if they have fibrosis or they have an indication of reduced pump function with an MRI? Then there are patients who most likely will need earlier intervention than...
Yeah, I'll throw it open to others, but we really haven't been, in our department, haven't been able to get good fibrosis data from MRI just because of all the technical challenges. So I'm not sure whether others...
I agree. And also the question maybe is, do we still know who has progressed too far and who can we reverse in AF if we even would know what the atrial cardiomyopathy is, right? And then it comes down to what Jason and Rada just said, to all the risk factor management. Maybe, that's my opinion, it plays an even higher role in those patients with a more progressed disease to target all of those other risk factors that we have, because we are not that good with ablation outcome in this cohort. Not yet. I mean, I'm willing to see if with new ablation technologies, and we're going to hear this in the next debate, or better strategies, we can improve, but I think we're not there yet.
Just one thing to add is also, it's very important to keep in mind what is our outcome, right? So if you look at some of the studies that have used machine learning or AI to predict ablation recurrence after an intervention based on all these criteria, is that what matters, right? Like, to your patient in your hospital or in your clinic, if you can intervene and improve their quality of life and prevent them going back to the emergency department, even with recurrences and burdens of 5% in the persistent AF population or 1% in the paroxysmal population, what's more important? So is it their quality of life, the fact that they're not seeking emergency care or hospitalization? If they can live with a low burden of paroxysmal AFib, but they were persistent before, that's a success, right? And so I just be careful with how we define a meaningful improvement for patients, because it's hard to put that onto a binary outcome. And when we apply things like left atrial size, we're looking at binary outcomes like arrhythmia recurrence. We're not looking at the whole totality of benefit in terms of patient-reported outcomes and things.
Yes.
Is there time for one comment? Or?
I have a final question. Sorry for you, Jason, again. And it's is related to one online question. That is, do we have enough electrophysiologists to perform ablation in all symptoms and about burden, but about our capacity to treat all these patients? I mean, the numbers are...
That's it's an important question, and you know, there's no question in the era of PFA, the learning. But it also, the other side of the equation is just thinking very carefully about when is the time to do it. And so just to the question that you asked to begin with, to Jason, and I think I would just reiterate what he said, which is that at the point that it's intrusive on lifestyle, at that progression point, I think it's very clear that that patient requires an ablation. And I think, yes, we'll be faced with a very large burden of patients, and we really do need to think carefully about our resources. But for patients with a single episode who might have another episode 2 years later, I think we can afford to wait until we understand what the natural history is and until they reach a progression point where it becomes more challenging, because if we don't, we'll certainly have a tidal wave on our hands.
Okay, thank you very much. A big applause for all these debates. The next debate is about pulmonary vein isolation alone is not enough. A personal approach is required in persistent AFib ablation in persistent AFib patients, and the protagonist will be Dipen Shah from Geneva Hospital in Switzerland. So, Dipen, please.
Professor Marino, Professor Blomstrom, ladies and gentlemen, friends and colleagues. It is indeed a distinct pleasure to be here in front of you and have the opportunity to defend the following statement. Pulmonary vein isolation alone is not enough, and therefore a personalized approach is required in persistent atrial fibrillation patients. These are my declarations of interest. And let's start straight away. I've emphasized the fact that PVI is the cornerstone, but is it enough? On the left-hand side, you have contemporary data from the contact force sensing PVI. And they found that 20% of patients with durable isolation of all pulmonary veins had recurrence of atrial fibrillation within 4 to 6 months after PVI. So it's not enough in PAF. And when we look at persistent atrial fibrillation, my colleagues from Bern restudied 26 of 30 patients with persistent atrial fibrillation. And beyond the blanking period, 23% of these 26 patients had arrhythmia recurrence. Recurrence had occurred in 33% of patients with complete isolation of all pulmonary veins and in 9% of patients with PV reconnections. So PVI alone was manifestly not enough, even in PEAF, as you can very well see with this very latest data. And if you look at new energies and PFA in particular, you have registry data that shows that a significant percentage of patients with durable PVI at restudy also still have significant recurrences. Now, persistent atrial fibrillation, it must be acknowledged, is a beast of a particular nature. It's a variable and progressive disease. And let me show you 3 classic examples. Upper left is a patient with 65-year-old with long-standing persistent atrial fibrillation with a left atrial volume of 90 and a right atrial volume of 126. Extensive ablation was performed beyond the PVs. On the right-hand side, you have a patient with a left ventricular ejection fraction of 25%, persistent atrial fibrillation from a tightened cardiomyopathy, and a left atrial volume of 250 ml. All, again, extra PV ablation. And bottom, you have a long-standing persistent atrial fibrillation patient with severe biatrial dilatation, a left atrium of 280 ml, and a right atrium of 400 ml. So yes, they come in all sizes and all shapes. And as you all know, personalized medicine has had its heyday, is having its heyday in the context of genetic precision medicine and oncomedicine. So the statement is valid. Personalized medicine is about tailoring a treatment as individualized as the disease is variable. And I think in ablation we can use that same motto, but I might like to remind you that personalized ablation is already being practiced in a matter of speaking. How? Well, in terms of patient selection, in terms of exclusion criteria for excluding patients with very large left atria, presence of left atrial thrombi, significant severe comorbidities. And then when you're using different forms of ablation strategies, most labs will say, I will use this for paroxysmal, I will use that for persistent, I will use this for first ablation, I will use that for a redo ablation. And then I might or I might not use adjunctive ablation strategies for this or that patient. And then, of course, this is the era of individualized management of risk factors. So you have high blood pressure, you treat your blood pressure, you have weight loss issues, you have glycemic control, sleep apnea treatment, smoking cessation. All of these are individualized, personalized management options. Yes, that's not ablation, but that is an important and powerful adjunct to ablation. So what is there in terms of standardized ablation strategies? Well, it's PVI, it's re-PVI, it's re-PVI. And then it's PVI plus posterior wall ablation. Or it's PVI plus linear lesions and VOM ethanolization. And then what? Well, fibrosis is an important target for us physicians who take care of atrial fibrillation, and personalized strategies focus on this feature. So low voltage zones, complex fractionated electrograms are targets. Phase activation mapping based targets have been evaluated, as you well know. MRI fibrosis targets we already spoke about a little bit. Selective posterior wall isolation as opposed to standardized posterior wall isolation is an option. Selective linear lesion creation, again, is an option as opposed to empiric linear lesion creation. And then there is, of course, individualized extra PV foci ablation, and then all these AF complexity and signal analytic parameters such as fast cycle lengths, dominant frequency, spectral organization indexes, and sample entropy as targets. The aim of this is to reduce unnecessary ablation, to reduce redos by providing higher efficacy, and that is the basis of what our treatment should be. Let's look at some contemporary examples of standardized adjuvant ablation strategy. The CAPLA study from my colleagues in the Southern Hemisphere, 338 persistent atrial fibrillation patients randomized in 11 centers worldwide. So they were randomized to PVI plus empirical posterior wall isolation versus PVI alone. And as you can see from the time to recurrence curves, there was no significant difference in atrial arrhythmia recurrence outcomes. No difference at all. As a counterpoint, there's this study that dates back to 2018. In this series of 102 patients with persistent atrial fibrillation, a group of German investigators evaluated circulating microRNA-21 levels. In this group of 102 patients, they did low voltage area mapping and segregated their patients into two groups of different extents of low voltage areas, less than 10%, 10 to 30%, and more than 30%. And they correlated this with one microRNA-21, a non-coding RNA which has post-transcriptional efficacy on cardiac fibrosis. They found that with a majority PVI-based strategy, the patients with large amounts of low voltage areas did poorly. And they found a perfect correlation, or a very good correlation, with increasing microRNA-21 levels. So the higher the low voltage area zone, the poorer the outcome, and the higher the microRNA-21 levels. So here is an innovative study that looks at a biomarker that allows you to plan and to segregate your patients into those who would and would not respond from PVI alone. Yet another study, another innovative EP test guided personalized treatment. 144 patients with persistent atrial fibrillation were mapped. 33 had low voltage areas, 111 did not. So then the group of investigators evaluated what to do with this group of patients without low voltage areas. And they performed adjunctive posterior wall isolation only in those patients who had a short refractory period in the posterior wall, or had a refractory period that was shorter compared to other areas in the posterior wall, or were inducible into AF or atrial tachycardia by stimulation of the posterior wall. And they found that in this group of EP-targeted selective posterior wall isolation, they did significantly better than the non-low voltage area group without these EP-based criteria and, of course, without posterior wall isolation. So there is an AFib substrate in the left atrium with an altered electrophysiological function, even when there is no low. And then what about MRI atrial fibrosis? The DCAF2 study, 843 persistent atrial fibrillation patients randomized in 44 centers worldwide, randomized to PVI plus encircling ablation of MRI fibrosis versus PVI alone. And again, as we can see from the time to recurrence curves, there's no evidence of better rhythm outcomes. So what can I say? Some forms of individualization, personalization are not as good as others. And perhaps we don't know enough about MRI. On the other hand, there is the ERASE-HF study that came out in 2022, low voltage myocardium guided ablation trial of persistent atrial fibrillation, low voltage categorized by 0.5 millivolts or less, patients randomized to PVI only versus PVI plus substrate modification. So substrate modification was only performed in the group if low voltage areas were detected. Low voltage areas, of course, were detected in a minority of patients, 36%. But there was a second level of personalization, that is, the individual area and zone of low voltages varied from one patient to another, and that was individually treated by a personalized ablation strategy. And here you can see the time to recurrence curves show that the subgroup with the additional substrate modification with 2 levels of personalization did better with an intention to treat primary efficacy endpoint. The stable SR3, although in patients with paroxysmal atrial fibrillation, is a 14-center study prospective in more than 65-year-old paroxysmal atrial fibrillation patients, again in whom low voltage areas were targeted in a personalized fashion, in addition to circumferential PVI isolation. So the circumferential PVI isolation plus group did better than the CPVI alone group, as you can see, with the statistical significance. And the low voltage area group was normalized to the non-low voltage area group with the addition of individualized substrate ablation. Again, low voltage areas were detected in 41% only, so what about the rest of the 60%? That's a question that remains to be answered. And then I showed you the Kaplan study was inconclusive, did not support empirical posterior wall isolation. But when you look at the sub-study from the group of Kaplan patients who were in AFib at the procedure time, and you look at the posterior wall rapid cycle lengths, those with the slower posterior wall activity did better than the ones with the rapid posterior wall, sorry, the other way around. The slower posterior wall activity did better than the rapid posterior wall activity, and the rapid posterior wall activity subjected to posterior wall isolation did better than those who were not subjected to the posterior wall isolation. So rapid posterior wall activity is an electrophysiological marker of an individualized therapy of posterior wall isolation. We have looked at PVI ablation requirements. And in a 70-patient series, we were able to obtain in persistent AFib patients a 76% AFib-free survival. And I'll draw your attention to the fact that in this stepwise series, we validated the procedural outcome of non-inducibility or termination of AFib into prognostic benefit. Required additional coronary sinus ablations only, 16% required additional left atrial ablations beyond this, and 9% required additional right atrial ablations to achieve this endpoint. So as you can see, a digressive amount of ablation is required to attain progressively good results, which is the aim of a personalized approach. There is corroborative data from a multicenter study in China, a multicenter prospective randomized clinical trial of persistent atrial fibrillation patients with right atrial dilatation, in whom PVI plus left atrial linear lesions and ablation of electrogram-based drivers were performed in all patients. Of course, that's a form of personalization, let me remind you, because not all patients have electrogram-based driver sites. And then these patients were randomized to adjunctive right atrial ablation versus left atrial ablation only. So this is a second level of personalization. And as you can see from the time to recurrence curves on the upper right, the left atrium plus right atrial group had a higher rate of acute AFib termination. They had a higher freedom from atrial fibrillation and atrial recurrence at a follow-up of more than a year. And although I don't show the data here, they had reduction in right atrial size and reduction in tricuspid regurgitation. And finally, although I don't generally indulge in character assassination, this is too good to pass up. This is a recent study for ablation for persistent atrial fibrillation using the lattice PFA RFA catheter. It is a 9 millimeter expandable mesh catheter-based catheter ablation tool, which uses both PF and RF. 28% persistent AFib patients underwent PVI. Only 13 had an anterior line, 19 had a roof line, and 1 had a CTI block. 100% acute efficacy. A safety profile was exemplary, and short-term follow-up was very, very encouraging. And here, of course, there is the element of individualization. Only if the following findings were detected, a substrate modification with linear ablations was conducted. Low voltage area, less than 0.5 millivolts, or conduction time from the beginning of the P wave to the left atrial appendage was more than 100 milliseconds, indicating conduction delay. Only then was either linear lesion in the anterior wall or in the roof line enforced. Well, what is the significance of this? Well, this is because that comes from my antagonist opponent, Julian Chun, a single center study, which of course I think completely demolishes any argument that he might want to propose. So I propose we finish the session here. But anyway, let me summarize. I think we are well on the way to developing an ideal personalized ablation strategy for persistent atrial fibrillation, which should be, in my opinion, simple to evaluate and implement, which should be readily available, unlike low voltage areas, which are only present in a minority, applicable to the full range of AFib patients, with a high sensitivity and specificity for identifying extra PV substrate triggers. And finally, I think we must acknowledge that the advent of high resolution rapid mapping and pulse field ablation coupled to large footprint and single shot ablation devices is likely to shorten and possibly improve the safety even further of personalized ablation strategies, rendering them more attractive and practicable, in my opinion. And I'm going to rest here and watch with pleasure what arguments my opponent tries to develop. All the best, Julian.
Thank you, Dipen. So the cone will be given by Julian Chun from the CCP Center in Frankfurt. Julian, please.
Dear Jose, dear Karina, dear ladies and gentlemen, dear panel, dear Deepan, of course, you can all imagine and we all realize it is very difficult to debate Deepan Shah. I tried my very best. Therefore, my declaration of interest is, besides of debating such a legend, it will be very difficult as you've seen here. We all know Deepan is working and living in Switzerland, in Geneva, and it's a beautiful place. And of course, in such a beautiful environment, you also come up with very clear ideas, as it was written down in this paper, stating that the individualized, basically, approaches for catheter ablation of AFib, but there's still a lack of established ablation strategies which will limit clinical inference. So therefore, Deepan, I mean, you already answered basically our debate. But of course, I also share our dream of a personalized ablation. So of course, we all share this dream, but to come with solid data and to transform the dream into reality, we need, in the first step, a procedure which delivers 100% PVI durability in the first place. And secondly, then we will be able to separate patients who are PVI responders from PVI non-responders. And of course, in the third point, we then need randomized trials proving a benefit of whatever personalized ablation strategy. And as you can see here in Switzerland, there's beautiful castles and there's wise people, of course, who come up with beautiful ideas and dream. Whereas myself, I am working in Frankfurt, and in Germany, we have to do cases in real life every day. So therefore, of course, there may be a different angle and different perspective. But I will share with you 5 reasons, 5 P's why Deepen in this case is wrong. First of all, number 1, persistent AFib is ill-defined. Number 2, PVI technology so far have not been ready yet, but of course they improve. Number 3, persistent AFib mechanisms and ablation strategies beyond PVI are completely unclear. And number 4, already we know personalized ablation failed. And number 5, of course, it's important, primum non nocere. So therefore, in the first place, the best PVI has to be accomplished. And this is just from the yesterday's new guidelines. What is persistent AFib? Persistent AFib is AFib which are episodes which are not self-terminating, And here we go. Here comes data from Korean colleagues. And those colleagues implanted loop recorders in patients classified as persistent atrial fibrillation. And what they could observe in the mean pre-ablation of 48 days, that there are different patterns of atrial fibrillation. Of course, there is a group of patients which are continuously in persistent atrial fibrillation. But there are also 2 other groups which terminate themselves, and therefore, again, proving our clinical definition of persistent atrial fibrillation is very ill-defined. PVI. PVI is not perfect and has not perfect been in the past. This is still data, what you could expect in clinically selected persistent atrial fibrillation patients after 1 year if you do a solid and good PVI, roughly 70% in sinus rhythm. Of course, still, there is room for improvement, and we know in the majority of the cases, PVI reconnection did occur, and PVI reconnection is the major finding in the repeat procedure. But there is light at the end of the tunnel because new technology is able to increase also, even though the learning curves and our overall experience is still limited, is associated with a higher durability rate, but still not perfect, of course. But again, there's maybe some developments in future which can help us. This is the current, I call it the recipe of 8 applications. So 4 in the basket, 4 in the flower, but what we did in Frankfurt, we did add 2 in a nice, we call it the olive configuration. So we have 10 applications in total. And this is data which is still preliminary, not published, but it shows us where the direction is going into, because if 8 recipe. What is personalized ablation? And of course, we already talked about different strategies which could be exerted. I think I can skip it. But we also know that the STAR-AF trial, which prospectively tried to evaluate the additional effect and benefit of additional ablation, basically could not show any additional benefit if cafe ablation was performed or additional linear lesions were deployed. And this is why it's not too surprising, and we all know in the guidelines, PVI isolation is the way to go. And I would say the best PVI isolation is the way to go. And all additional sites beyond used to be a 2B classification. Number 4, personalized ablation failed. And this is also from the old days. And Deepan, you know much better than I. But many years ago, we believed, or we could see and we learned that the muscular sleeve or reaching out into the PVs are longer for the upper veins as compared to the inferior veins. And here, what was also observed was triggers were predominantly observed in the upper veins. And what did we do? We personalized ablation back then, and we only ablated upper veins. We took it off, and then the patient had the recurrence maybe next day. And so what did we learn from that? We just ablated and isolated all 4 pulmonary veins. So PVI only, or personal PVI failed. Personalized ablation failed also on top of durable PVI, shown here in the party PVI study. And in the party PVI study, 367 patients, 39 EP centers, and what did operators do? They did individualize their ablation strategy. And maybe sometimes they combined ablation strategies. But what they found was on top of PVI, there was no additional benefit, no matter what they do and what the combination was based on their individualized data from a prospective multi-center trial, which we performed in Germany. It's the ASTRO study. And we also compared empirical LA isolation with a cryoballoon versus personalized substrate ablation. And here you see the outcomes. We could not show any benefit of the personalized ablation approach. We spoke and we heard about ERASE. ERASE is an important study and also beautiful because of the loop recorder implantation, but also because of the message. We learned that only 1 out of 3 patients had, in fact, substrate, and the substrate was ablated. And this randomized trial showed the benefit for patients randomized to the group of PVI plus substrate modification. But if you look a little closer into the data, you will see that the success was driven, as you can see here, in the group of patients with PVI randomized to PVI plus substrate modification, basically by the PVI itself within that group, and also looking into the patients who received only a PVI isolation procedure. Here, 0, low voltage. The better outcome, again, was driven by the better PVI in the PVI plus substrate modification group. So keep in mind, those patients only received PVI. So there's at least some questions open. And another super interesting study, and Isabel, I'm sure she will comment on this, the tailored AF, shown and presented as a late breaker this year at HRS. And now we use artificial intelligence looking into the super personalized ablation targets. And it was randomized to the anatomical approach. And what we can find, and this is, of course, spectacular data, the primary endpoint, freedom from AF after 1 year, was significantly better if patients were randomized to the AI group. But if we take and if we use the, let's say, the more classic and established endpoints of freedom from AFib and atrial tachycardia, you see the difference is gone. On top of this, also the ablation RF time was 42 minutes versus 20 minutes. So therefore, yeah, it was personalized, it was individualized, but still, it did require more than 20 additional minutes RF time to get to those results. The last point, primum non nocere, refers to the DCAF2 study. And of course, we all like the idea of MRI-guided ablation, fibrosis ablation, and we also we learned that fibrosis detected by MRI is not too good, but the strategy to ablate those areas did not translate into any, let's say, arrhythmia or rhythm stability benefit. But on the other hand, we could also and had to note that it was associated with a higher rate of complications, as you can see here. It was 1, 2, 3, 4, 5, 6 strokes. It was 1. 32 additional deaths in the MRI group. So therefore, I would summarize the 5 Ps why deepen in this case, unfortunately, in the consensus paper, and you see here persistent atrial fibrillation. And interestingly, you see it's on a PVI-only approach. And then we have strategy also taking comorbidities into consideration, and then at least beyond ablation, we should individualize at this point in time. Thank you very much.
So thank you very much. It's my pleasure to invite the discussant, Isabel Reisenhofer from Munich, Germany. Please, Isabel.
Yes, dear Jose, dear Karina, it's a pleasure, and of course, Deepan and Yonggi. Yeah, I think you're both right and both wrong, if you want so. For me, persistent atrial fibrillation is really something that is fundamentally different from paroxysmal AFib. And looking at our ablation strategy, what we use is PVI, and PVI is something that focuses on that part of AF that we understand, which is the beginning. Why is AFib initiated? So we focus on preventing the onset of AFib when we do a PVI. And then later on, when we enlarged our PV isolation circles, we learned that we could also ablate by the same ablation strategy some part of the substrate that then maintains atrial fibrillation. But is that the only location for substrate maintaining atrial fibrillation? And I think that's the question that underlies this whole discussion in persistent atrial fibrillation, is really everything about ongoing AFib located close. And then the second very interesting question, and I think Yonggi and Deepan both addressed this very nicely, is are these other places where substrate is located as standardized as in paroxysmal atrial fibrillation, where we know that we have about 85% of patients where AFib is initiated by the pulmonary veins? And I'm afraid not. So my standpoint is very clear. I think that we have to individualize our ablation, because there will be an individualized located substrate which will not be as standardized in its location as for the initiating component of atrial fibrillation, which are the pulmonary veins. Why do I believe so? Well, I think we've seen the Kaplan trial, we've seen some very standardized trials where we try to have lines, standardized things without really looking at the atrium itself. And why did they fail? And that's very interesting. I think because persistent atrial fibrillation in reality is the common path, the common end path of different, very different diseases that are located in this atria. The one might be this fibrosis of the fibrotic component, which is addressed by going after low voltage areas. But we've seen in ARRAISE AF only about 35% of persistent AFib patients have these low voltage areas. So what about the other 65%? Why is AFib maintained in these other 65% and does not stop by itself? Then another thing might be that the electrical properties of these myocytes are maybe just different than in other atria. So they might have shorter refractory periods, and that has been shown in bench testing before. So how can I address these ones? And so on. So I think in the end, looking at all the data that we have, we will probably end up with a fascinating high rate of success for PVI only, and we should be able to pick these patients and to provide them only with PVI. But we have then about 40% of patients who would need more, 40 or 50, and the question is, what do they need more? And there I'm totally convinced that we need then an individualized approach. And why do I think so? Because in the Taylor AF study, which we just presented in HRS in last May, we could show that this individualized approach, looking at electrophysiological properties of certain areas of the atria, and then going after these, when we apply this, then we can eliminate atrial fibrillation in a much higher percentage of patients. And you could see in the graphs that Yonggi Chun showed that we are able to eliminate AFib in a very high percentage of patients. The overall arrhythmia burden was almost the same in both groups, but most of the recurrences in these individualized treated patients were atrial tachycardias. And this is a regular arrhythmia. That's something understandable. And that's our problem with persistent AFib. We are in front of an arrhythmia that we don't really understand. If you ask 4 EPs, what is persistent AFib, you get 5 answers, or maybe 6. So in the end, our problem is we do not understand atrial fibrillation. And I think it warrants then a trial and also ablation strategies that eliminate this ununderstandable arrhythmia to get to an arrhythmia at least, or maybe no arrhythmia, or at least to an arrhythmia that is understandable and then treatable. So yes, I think we need these individualized approaches because persistent AFib in the end is the common path for very different diseases. And I just want to get back to that initial question and get you both also initiated on this discussion. What do you think then, when you think of an individualized approach, how could we, first of all, identify patients who profit from PVI only, and then the second, what kind of individualized treatment is there at scope? What do you see that we should use? Thank you.
Thank you very much, Isabel. Any questions? I think I have a question for the group here. If you are ablating persistent AF with PVI plus ablation beyond that, isn't it more difficult to evaluate whether your extra lesions are actually durable? Because it creates gaps. You have the risk for intra-atrial tachycardia, macrorental tachycardia, and when evaluating efficacy, you are evaluating atrial arrhythmia per se. You're not usually separating AF recurrence and atrial tachycardia recurrence. So it's difficult to learn about the procedure. I think that. And also, we evaluate efficacy by the first time of recurrence. We do not use atrial fibrillation burden as endpoints. Do you have any comments to these?
So, Karina, that's a very well taken point, and I will start by harking back to the most notorious study that I have had the privilege of reviewing and talking about over the years. It's STAR-AF2. I think one of the main reasons that it does not show a significant difference with ablation is the fact that without a visible endpoint, and that this was the days before contact force mapping and with verifiable objective lesion creating parameters. We can always argue about why it did not show, and this is certainly a hypothesis in my mind. But to get back to your point, yes, when you're ablating extra PV, creating extra PV ablations, it is critical to be able to show that you're creating homogeneous transmural lesions in which are contiguous lines of or regions of block. And today's technology of rapid high-density mapping allows you to do that with much greater precision and much greater speed than when we started out in this journey, say, 20 years ago. What we see as a result of that is with atrial tachycardia and a significantly higher capacity in providing curative suppression of these tachycardias at later times in the follow-up following extra PV ablation. I think for me, over the last 25 years of pursuing progressively increasing and progressively more rigorous ablation inside at the pulp PV ostia and outside, this is the main lesson that you need to be able to show that you have durable contiguous lesions without gaps. And verify this over at least 25 to 30 minutes post-lesion.
Can I just short comment on this?
Yeah.
Maybe if we take it even before ablation, the whole mapping, where do we start with an individualized approach, right?
Yeah, and also to jump on that line of thoughts, I think I would also, first I also agree, of course, we need a clear EP endpoint on acute level, which should has to translate into, let's say, long-term level. But this is something we are still lacking, and we have to admit. This is with contemporary RF technology, cryotechnology, we are not there yet. Even with PFA, we are not there yet. So therefore, this prerequisite, unfortunately, is not really given. But I wanted to also to address the point coming back to persistent atrial fibrillation and substrate identification or definition. Deepan, you showed, for instance, the data from the ERASE trial. In the ERASE trial, substrate was defined as low voltage 0.5 millivolt in sinus rhythm. Therefore, this opens, of course, the big box of how to define voltage or how to low voltage areas in what rhythm with using what catheters. So it is getting even more complex, maybe, to bring it up to this. The other thought is if we think about personalized or individualized strategies, we also discussed long linear lesions and also vein of Marshall ablation, etc. But to me, this is not individualized. This is an empiric ablation strategy with, of course, which can contribute to maybe increased rates of sinus rhythm. But again, and this comes back to need, or it needs durable lesions in the end of the day. And so therefore, it also at least centers on my perspective on the durability. Is it PVI durability or linear lesion durability or whatsoever? But durability of lesions is key.
Before we just move on from there, I'd like to respond to a point that Julian raised. Linear lesions have been used empirically, but what I'm suggesting as an integral part of personalized treatment is selective use of linear lesions, such as selective posterior wall isolation or selective anterior line or selective roof line. So that is actually a different beast.
Yeah, and I think that is very important to raise, because now with the PFA technology available, and what is increasingly done is the ablation apparently comes at no cost. You know, it's like, oh, we don't have complications, we don't have PV stenosis, we don't have esophageal complications, so let's just do this. And it's an ablation strategy, like sort of, I do it because I can do it. It's not because I should do it or because I mapped something or because I found out that this is, in this individualized patient, the right way to go. But it's just like, I do it because I can do it and there's no cost to it. And that, I think, is a very, very dangerous development, because you go on ablating a lot more and more and more. And that's the point that Yongi also did, is that, of course, we had the double of RF time in the Taylor AF trial. But if you look at the overall time, 20 minutes of RF for a PVI, it's not a lot. That was done with high power short duration. And then doubling it to 40, it's still okay. But performing PFA all over the place and erasing the whole posterior wall, that is something that destroys a lot of atrial tissue without evidence that I should do it. And that's what I think is the beauty of a personalized approach, is that you identify the things that you should ablate. And then, of course, I agree totally, you have to have a decent lesion there.
Yeah. Before you, Julian, I would like to ask the panel, what is your current policy with these patients? So what is the technique that you are using, and if you are personalizing or you are treating all the same? And I would like to ask all of you, all the panel, including the previous speaker. So starting with you, Julian, although I think it's quite clear.
Yeah, what we do for all first two procedures is PVI. If patient had an history of or tachycardia, changing into tachycardias during the case, of course, we would also address those clinical tachycardias. We would stand away from empirical or individualized or other lesions in the first place. And this also is maybe something, because we spoke about and discussed limited resources, also something to keep in mind. The PVI is faster than, of course, all the other additional lesions.
Deepen?
So, as I alluded to in my slides, we do an individualized approach, personalized approach, targeting non-inducibility or termination from the first procedure onwards. And that allows us to do about 28% of patients only PVI, and in the rest additional ablations. And I'd like to just allude to what Julian said. Although our protocol means that we spend a lot of time on individual patients, his very useful paper with the AFERA study with the selective strategy of additional linear lesions was accomplished with a mean procedure time of 94 minutes.
Yeah, we do if they come in persistent AFib, we do a personalized approach by using the AI-guided Volta system and the PVI with high power short duration. If they come in sinus rhythm, we do a PVI, and only if there are recorded regular atrial tachycardias, we do additional lines based on the individual low voltage or non-low voltage areas.
So we do PVI only in most patients for the first two, except if they're long-standing persistent AF, then we kind of have the trend now to actually do what you don't like, Isabel. We do PVI and posterior wall isolation in those patients. And what I really appreciate in patients coming back with persistent AF is when we had an index procedure where we have the knowledge about the voltage so that we can plan the second procedure. But this is obviously something we do not have that much anymore because there is a switch towards single shot devices in first two PVIs.
I realize we're at the end of time, so we enroll patients in STAR AF3 and we enroll patients in COAST AF, which is a substrate study. Shows that there's value.
Yeah, we do PVI alone. We will look for substrate, and if it's extensive. But the one point I would make about substrate is we and this is to Julian's point, we don't use a voltage cutoff. I think it depends on all the factors Julian mentioned, and we look for abnormal signals, long fractionated signals in sinus rhythm, the sorts of things that you see in maybe 20 to 30% of persistent atrial fibrillation patients. And if you find that type of very clear substrate, then we will ablate that.
Thank you.
So that will be the last words. I would like to thank the excellent speakers and discussants, my co-chair, and the audience for listening. We have much more to learn about AF ablations, and welcome back. Thank you.
But if Monday was a holiday, such as Easter Monday, there was no increased risk of myocardial infarction on that day. Recent data from a very large data set, more than 280,000 patients with myocardial infarction, comes from the Sweetheart Registry. Looking at the exact time of symptom onset,
Hello. Welcome, everybody. It's great to see such a large audience here for this main session, going into a deeper dive on the 2024 ESC guidelines for the management of elevated blood pressure and hypertension. My name is Bill McAvoy from Galway, Ireland. I'm co-chair of these guidelines, and sitting next to me is Professor Rian Towes from Montreal, Canada. And we'll both make presentations today on our guideline. And in addition, we have 3 of our task force members who will make presentations as well. We recognize that the overview session this morning was limited in our ability to go into the guidelines in detail, and so we're happy to have this opportunity to speak to such a large audience and to go into a deeper dive on these guidelines. And hopefully, if there was any questions from this morning, we'll have answered them by the end of this session. I will say that there are no questions from the audience for this session, but there are opportunities to ask the task force questions later in the day, and we'll give you details on further sessions at the end of this session. So without further adu, I'll welcome and introduce again Professor Rian Taus, who is co-chair of these guidelines and who will be making a presentation on a robust evidence-based process that defines new treatment recommendations.
Thank you, Bill, and it's a pleasure to be here today and to start this wonderful session really highlighting how robust and what a rigorous process it has been for us to define the new recommendations, the 2024 guidelines on elevated blood pressure and hypertension. Now, of course, the question arises to so many of us working in the clinic, do we need new guidelines? Do we need new hypertension guidelines? Well, I'm always reminded about the very famous Shattuck lecture that Avram Shabanian gave when he spoke about the hypertension paradox, defining this as more uncontrolled disease despite improved therapy. And he made that statement and wrote a beautiful paper in the New England Journal of Medicine in 2009. However, in 2024, the prevalence of hypertension continues to increase. The number of patients effectively managed remains suboptimal. We know that blood pressure control is actually worsening, and particularly in women. And we also know that hypertension is the major risk factor for morbidity and premature death globally. I should remind you about our efforts in doing a better job in terms of controlling blood pressure. And this is just one example of many studies that really defines to us how bad a job we're doing. In this study of over 2 million individuals, we can see that the number of individuals who are aware of their hypertension in both men and in women is quite high, about 50 to 60%. Of those that are aware that they have hypertension, we can see that about 30 to 35% are actually treated. But we can see that in both men and in women, as indicated by the dark blue graph, of these, less than 10% are actually controlled based on blood pressure targets that were actually defined a number of years ago. So indeed, similar to what Shabanian said, we certainly have huge challenges and the hypertension paradox remains. Now, why is it that high blood pressure, elevated blood pressure and hypertension are so critical with respect to the morbidity and premature death? Well, we know that elevated blood pressure and hypertension lead to hypertension-mediated organ damage, and there are many organs, as we can see, that are influenced by high blood pressure. And ultimately, this target organ damage is what results in the consequences of high blood pressure, and that is cardiovascular disease, stroke, chronic kidney disease, and also increasingly evident vascular dementia. So why do we need to update our hypertension guidelines? Well, this has been a very exciting time in the world of hypertension. There's some new clinical evidence. We need to address previous gaps. In fact, for a long time, we haven't had hypertension clinical trials, and so we would say this is a new era in terms of having many new hypertension clinical trials, looking at some new antihypertensive approaches. It's important to relook at controversies, whether this may be definitions, thresholds, or targets. And also, we need to translate new knowledge into clinical practice. And finally, guidelines may lose their clinical relevance as they age and newer research and new knowledge actually emerges. So the areas that we need to discuss in terms of limitations also need to be addressed. And there are a number of limitations because guidelines are not perfect. We need to address that there may be a lack of high-quality evidence resulting in guidelines that may be based on consensus. that studies informing recommendations may be misleading due to poor study design and biased results. The evidence may be misinterpreted by guideline authors due to differences in opinion, and recommendations may be influenced by vested interests of guideline authors. So indeed, we do recognize the limitations. However, guidelines certainly are under the spotlight, as are many clinical guidelines. And in fact, this was highlighted a number of years ago in a publication, as we can see in JAMA, where it was titled Scientific Evidence Underlying the ACC-AHA Clinical Practice Guidelines, was concluded that recommendations were largely developed from lower levels of evidence or expert opinion, and to exercise caution when considering recommendations not supported by solid evidence. And an associated editorial at that time actually said, reject the calls for adherence to guidelines unless there is evidence of appropriate changes in the guideline process. And a very provocative title, Are Guidelines for Treatment of Hypertension Actually Trustworthy? A paper that came out in JACC in 2019. Well, in order to ensure that our guidelines are robust and are rigorous, we, like many guidelines, need to improve the process of writing guidelines and to expand the evidence base. And building on the Institute of Medicine, which defined a number of processes in 2011, there are a number of standards for the development of rigorous and trustworthy clinical practice guidelines so that indeed we can optimize patient care based on evidence. And the standards for developing trustworthy guidelines, as indicated by the Institute of Medicine then, were to establish transparency, and indeed we and all the ESC guidelines do adhere to this. Management of conflict interest, indeed a very robust process here at the ESC. Guideline development group composition, we have been very all-encompassing and diverse in terms of our composition of our development group and task force. The clinical practice guidelines need to undergo review, systematic review, and very importantly, this needs to be evidence-based, and the evidence tables are provided in our guidelines, establishing evidence foundations for and rating strengths of recommendations, again, a robust process that we follow, articulation of our recommendations, standardizing the processes, voting across the task force, and of course having very rigorous external reviews of over 100 reviewers reviewing our process. So, the process that we have been following over the past 2.5 years has indeed been robust and rigorous. We started the process about 2.5 years ago, as we can see. We have undergone a phase of setting up the process, writing the document, reviewing the document that has undergone extensive external review, and of course, publication. And in order to do this, we have, as we have seen Bill mentioned, 2 co-chairs. We have worked very closely with the ECS staff almost weekly for 2.5 years. We have a task force of 2 in-person meetings and 5 virtual meetings over the course of this year. We've had 3 rounds of peer review with over 100 independent reviewers, and as I said, 2 rounds of voting to ensure that the guidelines, the new recommendations that we present, are indeed evidence-based in the most robust and rigorous way. We have followed, obviously, the recommendations that are defined by the ESC. These are the classes of recommendations, Class 1, Class 2, 2A, 2B, and 3, and we have used the appropriate wording to ensure consistency of the guideline recommendations. The levels of evidence are also harmonized. A level of evidence A As we can see, data derived from multiple randomized clinical trials or meta-analyses, levels of evidence B, data derived from a single randomized clinical trial or large non-randomized study, and then levels of evidence C, which may involve consensus or opinion. So in terms of the hypertension guidelines, the evidence has resulted in 57 new recommendations and many updates of previous recommendations. Highlighted here are those areas where we have included new recommendations relating to measurement of blood pressure, the definition and classification of elevated blood pressure and hypertension, and the involvement of cardiovascular disease risk assessment, diagnosing hypertension, investigating underlying causes, preventing and treating elevated blood pressure, managing specific patient groups or circumstances, and patient-centered care. Some new concepts that need to be highlighted, and you will notice from the title of our guidelines, is that the title has changed to the Guidelines on the Management of Elevated Blood Pressure and Hypertension. And we have included this new blood pressure category of elevated blood pressure as being an office systolic 120 to 139 or a diastolic of 70 to 89. And I will just remind you, when we look at cardiovascular events, as we can see in the graphs on the right-hand side of the panel, we can see that cardiovascular events already occur when blood pressure is as low as 115 millimeters of mercury systolic. The highlights of our 2024 guidelines are indeed to aim for a target systolic blood pressure of 120 to 129 in treated patients. For a class 1 recommendation for drug or any procedure, we insisted that evidence had to show not only blood pressure lowering, but also improvement in cardiovascular disease outcomes. We have included sex and gender as an integral component of the document, and this is not just a standalone section within the guideline. We have also introduced important concepts with respect to the implementation of guidelines and the challenges and the needs that we as a community need to work on in ensuring that these guidelines are indeed implemented. And we believe that the text that we have provided is user-friendly, it provides practical aspects, and that there's a very large supplementary text that provides any of the academic background knowledge. I encourage everybody, please, to download the app. It's a beautiful app. The guidelines are presented on the app and very user-friendly. They are available for free for everybody to use, and I encourage you to start downloading the app right after this session. But we would never have been able to get to where we are today if it wasn't for the amazing work that Bill and I have had the opportunity to do working with the incredible task force. As we can see here, we have a very diverse group of members on our task force. I especially want to acknowledge Rosa Maria and Kian, who worked with Bill and I very closely as coordinators, and of course all the members on the task force. We have representation from numerous councils and other organizations, and also I need to acknowledge the incredible support that we have had from the ESC staff, and particularly Christelle, Naomi, Louise, Matthew, and Natalie. And with that, I'm delighted to open this section where we'll now learn more about the specifics related to the new 2024 guidelines on hypertension. So we will move on to Bill, who's going to tell us something about the new classification definitions of blood pressure and hypertension. Bill.
Thank you, Rian. And So now we're going to get into the meat of the document and try to give you some flavor of the highlights of the document over a number of presentations to come. I'm going to start with probably the simpler presentation, and I'm going to talk a little bit about the hypertension categories that we put forward in these guidelines, and a little bit about the what and the why. These are my interests. So we do provide new categories in these guidelines, and just to review, the prior guideline from 2018 had 7 categories based on blood pressure thresholds. We have gone with 3 categories, and I'll go into detail on each one in this talk. The first category is non-elevated blood pressure, which is a blood pressure less than 120/70 millimeters of mercury by office blood pressure assessment. The next category is elevated blood pressure, 120 to 139 systolic or 70 to 89 diastolic, again by office blood pressure. And the last category is the traditional classic definition of hypertension, greater than 140/90. Each one of these categories we think have very important different aspects to their care. The non-elevated blood pressure category clearly need to be monitored and advice around lifestyle and so forth to maintain that status. For the elevated blood pressure category, which is a new category, we focus on risk stratification to identify patients who may be eligible for blood pressure treatment, particularly those who have a confirmed blood pressure over 130 on follow-up. And then the hypertension category, and we feel these patients are sufficiently high cardiovascular risk that most will merit blood pressure lowering treatment, although there are some caveats that we'll discuss later in these presentations. So I will say, before I move on to describing each of the categories, that a focus of this document, a strong focus, is on out-of-office blood pressure measurement. We do provide stronger recommendations for out-of-office assessment for both diagnosis and management than prior guidelines. And in that context, we provide the relevant thresholds for each form of out-of-office blood pressure reading. But we acknowledge that clinical practice will continue to be based in part, at least, if not in large part, on office blood pressure. So a little bit about the non-elevated blood pressure group. You may wonder why we didn't call this normal tension or normal, and the reason really was epidemiologic. My slides have done the freeze. So here we can see data from the Prospective Studies Collaboration, and these are well-established epidemiologic data. And you can see at every age category that the relative risk for cardiovascular disease increases. And at the systolic blood pressure level, that risk traditionally has been felt to increase from as low as a systolic of 115. So we know already that there's epidemiologic increased relative risks for blood pressure values that are lower than what we would use to define hypertension in the clinic. More recent data have been published, which would suggest that that lower bound below which risk no longer decreases is lower than previously understood. And these are data from MESA, from my colleague Seamus Welton and Johns Hopkins, showing that for patients who do not have other cardiovascular risk factors, so quite healthy subgroup of the MESA population, the relative risk for cardiovascular disease starts to increase from a systolic as low as 90. And similarly, these are data from Marius Arvanitis, and I was fortunate to be the senior author on this. These are genetic data, so genetically predicted blood pressure using polygenic risk scores has given us strong evidence that blood pressure as low as 90 systolic is a threshold above which we start to see some increased risk. And then finally, making the point that these patients don't necessarily have normal blood pressures, are data from indigenous communities, and these are just examples, one from Venezuela on the left and the other from China on the right, where we have hunter-gatherer populations who aren't exposed to the kind of Western environmental exposures that we are, who maintain over the course of their lives blood pressures that are in the 100 systolic. Okay, so we've talked about the non-elevated blood pressure group. Again, focus there really is on review, follow-up, lifestyle. Now we move to the elevated blood pressure category, and this is a new category, as I've mentioned. Here we have the office blood pressure between 120 to 139 systolic or 70 to 89 systolic. This is a category we felt was important to introduce really in the context of the most recent trials. We have trial data now, and I'll go through some of them, showing efficacy in terms of cardiovascular disease reduction to a target blood pressure of 120. And we also know in those trials that the entry criteria was pre-entry blood pressure of over 130. So we felt we needed to do something in that 120 to 140 range. And obviously cardiovascular disease risk assessment is one way to try and pick out the patients from that group, which is a large group. Again, there's a lot of disease in this group, to try and identify those with highest risk who may benefit from consideration of treatment. And we'll discuss that in the rest of these talks. And then we have our hypertension category, which I've already mentioned. So we recognize that the field of hypertension has moved with the evidence base. And on the top of this slide, you can see the big trials. This is a paper from New England Journal, Mark Pfeffer, and I think John McMurray was the other author on this, who just nice summary of how guidelines have changed over the years and how our definition of hypertension has changed. And we kind of come to lower and lower thresholds. And we felt that the new trial data really required us to have a rethink of how we categorize blood pressure in terms of this elevated blood pressure category. So what are those new trials? Well, many of them have been reported in the last, I would say, 5 years. And you can see here some summary data. So for trials randomizing patients, broadly speaking, to an interventional or intensive target of less than 130 versus a more traditional target of higher than 130. And you can see across the board that there's a strong trend in all trials to a reduction in cardiovascular disease events, and in many of the trials these reductions were statistically significantly. Most notable, you can see here, of course, is STEP, the Chinese Rural Hypertension Control Project, and ESPRIT, all published in the last year or two. And we're not talking about CVD, we're also talking about death. So for these more versus less intensive trial data, we have evidence from SPRINT, HCP, and ESPRIT for reductions in all-cause death as well. And then when you take a subgroup of those trials, a subgroup of them looked at a more intensive target, actually looked at 120 versus 140. And there again, you see a very strong trend for reduction in cardiovascular disease events, but also for death. But how are we going to pick these patients out? And we can't treat everybody with elevated blood pressure, with blood pressures between 120 to 139. And obviously these trials all used some form of risk assessment to enrich the trials with patients who have more events, which allowed the trials to be sufficiently powered. So we're really focusing on risk assessment in this category. And I'll finish there, and we'll talk more about the risk assessment in a moment. So just to reiterate, we have 3 broad categories with 3 different approaches to management. And we'll talk a little bit more about those approaches in the next presentations. Thank you.
Thank you, Bill. We'll move on to the next presentation given by Professor Farnes, and he's going to be talking to us about blood pressure measurement.
Thank you very much. Good afternoon, everyone. These are my declarations of interest. So over the next few minutes, this is an overview of what I'm going to talk to you about, which is largely about the changes in terms of blood pressure measurement and how that has influenced thresholds, diagnostic algorithms, long-term follow-up, and not forgetting the impact that patients have had in the development and review of this guideline, and a bit about patient-centred care at the end before we come to conclusions. So a bit of background. Self-monitoring in terms of out-of-office measurement has been around almost 100 years. In 1930, it was reported from the Mayo Clinic that a 25-year-old so-called intelligent male patient turned up with 3 years' worth of blood pressure measurements, which I think is probably the 1930s equivalent of someone coming in with an internet handout to your clinic, which you may be familiar with. His blood pressure was seen to vary with the diet, with seasons, and it went up at the weekends, which was put down to the usual diversions of a young, unmarried man. So I'll leave that to your imagination. Self-monitoring is now extremely common. Most surveys suggest that between 40 and 50% of people with hypertension are now measuring their own blood pressure, and this is internationally. We must also think in 2024 about the context that we find ourselves in. We're now a few years after the main impact of the global COVID-19 pandemic, but this had an enormous effect on the way that many of us practice. I'm a general practitioner, and in the UK, in March 2020, there was a massive change where many consultations suddenly became remote. And you can see from these data from Scotland that that hasn't returned back to normal. Still, in the UK now, about a third of primary care consultations are remote. And I know from my colleagues around Europe that many of you are doing remote follow-up still. So this is the context that we find ourselves in. So in terms of the new guideline, how have we changed and what is similar in terms of blood pressure measurement and screening? Well, you'll not be surprised to hear that we're still recommending the use of validated and calibrated devices with correct measurement, and we've got some nice information in the guidelines. You can see here in terms of infographics going into really very much detail about how one should measure blood pressure in the office, at home, and ambulatory monitoring. And we're lucky in Europe to have the STRIDE and many, indeed, international national societies which have lists of monitors that are validated. And so if we're going to use monitors for out-of-office monitoring as well as in-office monitoring, we should check that those are appearing on these relevant lists. You've just heard in the last talk about the simplification of the categories into non-elevated, elevated, and hypertension. And you will no doubt be pleased to know that hypertension in Europe is still hypertension. We don't have to rethink any of those that thresholds. But I think that these more simple categories will help us in our daily practice. These categories are obviously vary slightly as one goes from an office measurement to a home measurement and to the different types of ambulatory measurement, daytime, 24-hour, and nighttime. And you'll see from this slide that at the non-elevated blood pressure levels, as the blood pressure is 120 or below, certainly office, home, and daytime ambulatory are approaching the very, very similar measurements if you compare across the different types of threshold. And so that's reflected here. As the blood pressure increases, you can see that the thresholds for office measurement are slightly higher than the thresholds for home and ambulatory measurement, which fits with the evidence. But these comparisons are broadly similar internationally. So there's no big change there. In terms of screening, the screening recommendations have got a little stronger. Opportunistic screening is now recommended every 3 years for adults less than 40 years old and at least annually for those 40 or more. Where someone has an elevated blood pressure, so in that middle category you've just been hearing about, but they don't yet hit the risk thresholds, we recommend annual screening of blood pressure, and that's to make sure people don't fall through the guidance. Other forms of screening there's less evidence for, things like systematic screening or self-screening or non-physician screening, but it's hard to imagine how those types of screening would cause harm, and so it's fair enough to use those and then to take either a home or an ambulatory monitoring approach if someone's picked up from one of those more novel forms of screening. Those with falling in the middle category, the elevated blood pressure category, should have their cardiovascular risk done and an out-of-office measurement. Sadly, the measurement of blood pressure in people with atrial fibrillation is something that still hasn't been sorted out yet, and so we are recommending the use of manual monitors in people falling into that category. Some electronic oscillometric monitors are accurate in systolic blood pressure, but not very many of them, and very few are accurate for diastolic. So diagnosis. We're recommending that out-of-office measurement is used for diagnosis where possible in pretty much everyone, unless the blood pressure is extremely high. In other words, unless they've got accelerated hypertension. And that's to pick up people with white coat and masked hypertension. And it's because the diagnostic test performance of home and ambulatory monitoring is better than clinic monitoring. The protocol remains to screen, to confirm with ambulatory and home measurement. If you're unable to do that, to confirm with repeated office measurement, and then to make a diagnosis. And for those whose blood pressure is falling above 140 over 90, or the equivalent out-of-office readings, that's enough. If they're falling in the elevated region, so 120 to 139 over 70 to 89, in terms of office measurements or the equivalent out-of-office measurements, then we recommend doing a risk calculation, and if they fall in the higher risk, to treat and otherwise to monitor. And those with non-elevated blood pressure you can leave until your next screening round. Now, as I mentioned, patient-centered care is something that we have been very keen to think about in terms of these guidelines, and patients were involved from the beginning on the guideline development group, sitting round the table with the specialists in the various areas and giving their advice. And we were lucky to have some really excellent patient reps who were very, very clear about what was important to patients and pulled us up, to be honest, as people who are blood pressure specialists, if we were coming up with things which they felt were not appropriate for patients, and really pushing us to get a patient-centered guideline. They commented on all aspects, led the patient-centered section, and participated in terms of the review process, which, as you've seen, the review process was actually longer than it took to write the guidelines. So these have been very carefully reviewed. And you'll not be surprised to hear that there is a patient-friendly version of the guideline in development. Unfortunately, it's not quite ready yet, but that will be organised through the patient forum of the ESC. And patients were very clear that they wanted to self-measurement and self-monitoring of blood pressure should be central to the management of hypertension. I'll go on in a second to show you the evidence for that. But the recommendations are that for the long-term management of hypertension, we should be using self-monitored blood pressure to achieve better control. That it's recommended because, as well as improving control, it helps with acceptance for patients of their disease, allows them to see the variation in blood pressure from day to day, empowers them and helps in terms of adherence so it makes it more likely that they will take their medication. The evidence at the moment for using apps and so on over and above self-monitoring alone is less strong, but for many of us that's a convenient thing to do, and so that is included for the first time in these guidance as a possibility. It's not a strong recommendation, it's a maybe considered recommendation, but nevertheless it's there. Many of you will know that the evidence for self-monitoring is now very strong. There's more than 50 trials in the literature, several systematic reviews, which basically all show that self-monitoring, particularly when it's combined with some co-interventions such as nurse or pharmacist-led care, self-management or telemonitoring, leads to lower blood pressure. And on average, people who self-monitor can get relatively modest, but about 5 millimeters systolic blood pressure lower, which, as you know, on a population basis has a very significant impact. Patient-centered multidisciplinary care is another highlight of these guidelines, and not just in terms of the different members of the clinical multidisciplinary team, in terms of nurses and so on, but also thinking about task shifting and how that might help in terms of our clinic organisations. And things do not all have to be physician-led. Multidisciplinary teams consisting of pharmacists, nurses and so on have been shown to have really good impact on blood pressure control, and we're recommending that. To conclude, in terms of follow-up frequency, there's good evidence that one should follow up people pretty frequently while their blood pressure is not controlled, perhaps as often as monthly or even less, more frequently in those with very high blood pressures, titrating as you go along. But once someone's blood pressure is controlled, the evidence suggests that you need only see them about once a year, and that in fact if you follow up people too frequently with well-controlled blood pressure, you can get false positive raised blood pressure, and actually you'd be better off spending your time on those whose blood pressure is raised. So to bring this all together, in conclusion, my take-home messages are: we're in a different place post-pandemic, and hypertension care has changed. Screening with office measurement is consistent with our previous guidance. Out-of-office measures are now preferred for the diagnosis and long-term follow-up of hypertension. We recommend a patient-centered approach for all of our care. These guidelines represent an evolution rather than a revolution, and I recommend them to you. Thank you very much.
Thank you very much, Richard. Our next speaker is Dr. Cian McCarthy. Cian is a task force coordinator, so did a lot of heavy lifting in writing these guidelines, and is a cardiologist and assistant professor at Harvard Medical School and Massachusetts General Hospital, who also hails from Ireland. So Cian will give us a presentation on further details on risk assessment, as I indicated in my earlier talk, relating primarily to the elevated blood pressure category.
Thanks very much, Bill. It's a pleasure to be here today to present on behalf of the task force our recommendations related to cardiovascular risk assessment in the management of elevated blood pressure and hypertension. Here are my disclosures. Meta-analyses of randomized clinical trials have shown a benefit from blood pressure reduction in the prevention of cardiovascular events down to a systolic blood pressure of 120 millimeters of mercury, with no evidence of effect modification in the relative risk reduction in events across a wide blood pressure range. Meta-analyses of randomized clinical trials have also shown that individuals at higher risk for cardiovascular events derive greater absolute benefit from treatment. On the left here, with increasing predicted risk of cardiovascular events, there's increasing absolute risk reduction in cardiovascular disease events. So when identifying individuals for blood pressure lowering treatment, we want to identify individuals who derive a benefit from blood pressure reduction in terms of absolute reduction in cardiovascular events that exceeds the downsides of treatment, such as treatment adverse events and costs. Now, cardiovascular risk factors tend to cluster with increasing blood pressure, such that most individuals with hypertension, defined as a blood pressure at and above 140/90, have a 10-year risk of cardiovascular disease that is at or above 10%, a threshold which the task force felt was sufficiently high to warrant blood pressure lowering treatment in all individuals. In contrast, among individuals with elevated blood pressure, represented in the middle columns here, risk is more heterogeneous. Some, but not most, individuals have high cardiovascular risk in that blood pressure range. Nevertheless, because this represents a large population, a large burden of cardiovascular events is occurring among individuals with elevated blood pressure, who traditionally would not be treated using standard blood pressure treatment thresholds. Indeed, 30% of the disability-adjusted life years lost related to cardiovascular disease occurs among individuals with elevated blood pressure. So this is an unmet need for treatment in this subpopulation. Now, contemporary blood pressure lowering trials that have shown benefit from intensive blood pressure lowering have begun or have enrolled individuals beginning at a systolic blood pressure of 130 recently. But importantly, when doing so, they required participants to have increased cardiovascular risk. For example, in SPRINT, participants were enrolled beginning at a systolic blood pressure of 130, but they were required to have at least one of the following: an age of 75 years of age or older, established cardiovascular disease, chronic kidney disease, or a Framingham risk score of 15% or higher. And the risk criteria included in the SPRI and the CRHCP trials are also illustrated here. Both again required increased cardiovascular risk when enrolling individuals beginning at a systolic of 130. For all those reasons, the task force felt that risk assessment would be most useful among individuals with elevated blood pressure. That's the systolic of 120 to 139 or diastolic of 70 to 89, to identify that smaller subgroup within that range who have high cardiovascular risk, who are more likely to derive benefit from blood pressure lowering treatment. For individuals with hypertension, the task force felt that these individuals had sufficiently high both medium and long-term risk to warrant blood pressure lowering treatment in all. So in the guideline, we outline a 4-step approach to risk assessment for individuals with elevated blood pressure to identify that smaller group with high cardiovascular risk. The first step is to assess for sufficiently high cardiovascular conditions. And so if you have an individual with elevated blood pressure, you want to assess, do they have established cardiovascular disease, moderate or severe chronic kidney disease, hypertension-mediated organ damage, diabetes, or familial hypercholesterolemia. In the presence of one of these conditions, we recommend lifestyle measures, and after 3 months, if the blood pressure is still at or above 130/80, then starting pharmacological blood pressure lowering treatment. The one exception to this rule being individuals with type 2 diabetes who are young. Some of these individuals don't have a 10-year risk exceeding 10%, and so formal assessment of their risk should be considered using score 2 diabetes. And this figure illustrates those high-risk cardiovascular conditions. I'll draw your attention to established clinical cardiovascular disease. We define that in the guideline as heart failure or atherosclerotic cardiovascular disease, which included cerebrovascular disease, coronary artery disease, and peripheral arterial disease. And this is the formal recommendation regarding that. So it's recommended to use a risk-based approach for the treatment of elevated blood pressure, and individuals with moderate severe CKD, established cardiovascular disease, hypertension-mediated organ damage, diabetes or familial hypercholesterolemia are considered to be at risk for cardiovascular disease events. Now, in the absence of these high-risk cardiovascular conditions, we recommend that apparently healthy adults with elevated blood pressure have their 10-year risk of cardiovascular disease events estimated. And we recommend using SCORE2 or SCORE2 older persons. These are risk scores that were derived, calibrated and validated in European populations to predict your 10-year risk of both fatal and non-fatal cardiovascular events. And the task force advises that individuals with a risk threshold over 10 years of 10% or higher be then recommended for lifestyle measures, and after 3 months, if the blood pressure remains above that threshold of 130/80, pharmacological blood pressure lowering treatment should be started. If you're in the low risk group with a risk of less than 5%, we advise that you should intervene with lifestyle measures, and at 1 year, reassessment of risk and blood pressure should be considered. Now, if you fall into this middle group with a risk of between 5 and less than 10%, we advise that additional risk stratification should be considered, which I'll go through in the coming slides. And so here are the formal recommendations regarding 10-year risk estimates. So SCORE2 is recommended for individuals aged 40 to 69 with elevated blood pressure who do not have the high-risk cardiovascular conditions to assess their 10-year risk of fatal and non-fatal cardiovascular events. SCORE2 older persons should be used for individuals aged 70 years or older to predict their 10-year risk. Notably, this risk model adjusts for the competing risk of non-cardiovascular mortality in older individuals to reduce the risk of overestimating an individual's risk in individuals above 70. It's recommended that, irrespective of age, individuals with elevated blood pressure and a SCORE2 risk of 10% or higher be considered at increased risk for cardiovascular disease for the purposes of risk-based blood pressure management. And lastly, SCORE2 diabetes should be considered for individuals with type 2 diabetes to estimate their risk, particularly if they're young, less than 60 years. Now, if you have a patient who falls into this borderline risk group of between 5 and less than 10%, we advise that sex-specific and shared risk modifiers should be considered that, if present, would upclassify your risk such that you should receive lifestyle measures and, after 3 months, blood pressure lowering treatment if you're still at or above 130/80. And this figure illustrates these risk modifiers. So these are risk factors not including your traditional risk models like SCORE2, but individuals with these risk factors tend to have their risk underestimated using these risk models. So on the left, we have sex-specific risk modifiers. They include a history of gestational diabetes, gestational hypertension, history of preeclampsia, preterm delivery, one or more stillbirth, and recurrent miscarriage. On the right, we have shared risk modifiers that are shared by both men and women, and they include a high-risk ethnicity, family history of premature onset ASCVD, socioeconomic deprivation, autoimmune inflammatory diseases, and severe mental illness and HIV. Now, in the absence of these risk modifiers, if risk remains uncertain or a decision to start treatment remains uncertain, additional risk stratification with testing could be or may be considered with any of the following: measurement of a coronary artery calcium score, assessment of carotid or femoral plaque using ultrasound, measurement of cardiac biomarkers such as high-sensitivity cardiac troponin or NT-proBNP, or measurement of arterial stiffness using pulse wave velocity. If these are abnormal, again, your risk will be higher, and so we recommend lifestyle and, after 3 months, blood pressure lowering treatment if you're at or above 130/80. If any of these are measured and are normal, then lifestyle measures alone are recommended, and a reassessment of risk and blood pressure at 1 year should be considered. So in summary, individuals with hypertension, defined as a blood pressure at and above 140/90, are considered to be at sufficiently high, medium and long-term risk for cardiovascular disease, such that all should receive lifestyle and blood pressure lowering pharmacological treatment. Risk assessment should be performed for individuals with elevated blood pressure to identify the smaller subgroup at increased cardiovascular risk. And that risk assessment includes 4 steps: assess for high-risk cardiovascular conditions. In the absence of these, predict 10-year risk of cardiovascular disease events. If you fall into that borderline group, consider risk modifiers and consider additional risk testing. And if you have an individual with elevated blood pressure who is high risk, we recommend lifestyle measures to lower their blood pressure. But if after 3 months they're still at or above 130/80, then blood pressure lowering pharmacological treatment should be initiated. Thank you.
Thank you, Ken. We'll move on to the last presentation, and this will be given by Rosa Maria Bruno, a professor in Paris, and she's going to be talking to us about when to start drug treatment and the new blood-based treatment targets. Rosa Maria?
Dear Chairman, dear colleagues, I'm really pleased and honored to present this last presentation of this session, and I will go through some important aspects of these new guidelines highlighting the novelties. So I will speak about when to start treatment and which blood pressure targets must be achieved, and how to lower blood pressure, either with lifestyle measures or pharmacological treatment or device-based treatment. And then finally I will go through some specific aspects in some patient groups. So let's start with when to start treatment, and this is especially a link with the previous presentation by Ken McCarthy, and so now you are perfectly aware that we have a new classification of blood pressure, and that hypertensive individuals, regardless of age, regardless of risk, they deserve a drug treatment immediately. And of course, this does not apply to the elevated blood pressure subgroup. In these individuals, we recommend drug treatment only after a careful process of risk stratification that has been already described in detail. And it's summarized in this algorithm, and so we have to go through the condition who put the patients already at very high risk of cardiovascular events, and we can assess a score 2 and score OP, and treat individuals with a risk more than 10%. And then we should consider shared and sex-specific risk modifiers. And finally, we may decide to perform some tests in order to assess hypertensive-mediated organ damage, in order to decide which individual will be treated in the category of elevated blood pressure. Here you can see the new recommendations concerning when to start treatment. And so, briefly summarizing, in individuals with hypertension, we recommend to start immediately lifestyle measures and pharmacological blood pressure lowering treatment. And conversely, in individuals with elevated blood pressure and sufficiently high cardiovascular risk, we are supposed to start immediately lifestyle interventions, and if after 3 months of lifestyle intervention blood pressure is still higher than 130 to 80 millimeter of mercury, it's important that we recommend to start drug treatment even in this category. So, which are the blood pressure targets that are recommended in the new hypertension guidelines? We decided an approach which is a simplified approach and an intensive approach. So the target systolic blood pressure which is recommended is 120 to 129 millimeter of mercury, and this applies to most patients indeed, including patients with diabetes, patients with chronic kidney disease, with previous stroke, and with cardiac disease. And we decided also to apply the concept of the lower the better. So what we consider ideal in this range between 120 and 129 is indeed the lower bound, the 120. And this for the reasons that Bill McAvoy already explained in the previous presentation based on the evidence on trials on intensive blood pressure targets. But, of course, such an intensive target may not apply to all individuals. And in some individuals, an intensive blood pressure target is not tolerated, and in some individuals we have not sufficient evidence, or the risk-benefit ratio is not favorable. This is why in these categories of patients which don't tolerate an intensive blood pressure target, who have particular conditions such as pre-treatment symptomatic orthostatic hypotension, or age higher than 85 years, or moderate to severe frailty, or limited predicted lifespan. In this category, indeed, we suggest to have a target systolic blood pressure which is as low as reasonably achievable, which is the so-called ALARA principle. And we suggest that this target is in any case, if possible, lower than 140 millimeter of mercury. What it is important to stress is that these intensive blood pressure targets that are recommended in the new guidelines must be confirmed whenever is possible by out-of-office blood pressure, so by a BPM or by home blood pressure monitoring measures. And this is very important because and you already learned everything about the importance of out-of-office blood pressure in the presentation by Richard McManus. Here you can see the new recommendation about the blood pressure targets. So again, a simplified target which is available for most patients, which is a systolic blood pressure between 120 and 129. And in patients in which the intensive blood pressure target is not tolerated, we suggest the target systolic blood pressure level that is as low as reasonably achievable according to the ALARA principle. And we stressed about the condition in which this intensive blood pressure target is not applicable, which is the condition where the symptomatic orthostatic hypotension, or age more than 85 years, frailty, or limited lifespan. And finally, in individuals in which systolic blood pressure is already a target, it may be recommended to intensify treatment to achieve also the diastolic blood pressure target, which is between 70 and 79 millimeter of mercury. So let's move to how to lower blood pressure. So let's start with the lifestyle measures. In the field of lifestyle measures, we have some important novelties in these guidelines, and of course, we confirm the importance of reduced sodium intake, but we have a new recommendation about the importance of increasing potassium intake. And this can be achieved both with diet rich in fruit and vegetables, or can be achieved by sodium substitution with potassium-enriched salt. We give a 2A recommendation to the increasing in potassium intake in the guidelines, and this is a consequence of some important trials coming out in the last years, which demonstrated clearly the benefit in terms of reduction of cardiovascular events of salt substitutes. In terms of physical activity, even in this case, we have some novelties in these guidelines. So, of course, we continue to recommend to everybody to perform aerobic exercise training at least 150 minutes per week, and this remains a cornerstone in prevention and treatment of hypertension. But this can be accompanied by dynamic or isometric resistance training that can complement aerobic exercise training, and this is particularly important in hypertensive patients. I cannot go into the details of the evidence supporting this new recommendation, but there is a specific consensus document from EAPC and the EAC Council of Hypertension going into the details of this new recommendation for personalized exercise prescription in arterial hypertension. So let's move to how to lower blood pressure. In this slide, you can see the practical algorithm for pharmacological blood pressure lowering. You see that we recommend, as a class 1 recommendation, to start treatment with the low-dose double combination therapy. This combination must include a RAS blocker, a calcium channel blocker, or a thiazide-like diuretic. If blood pressure is not controlled after 1 to 3 months, we suggest to increase the number of drugs going to a low-dose triple combination therapy. If this is still not sufficient to have a blood pressure at target, we consider to up-titrate the 3 drugs in order to achieve the maximally tolerated triple combination therapy. At any step of the practical algorithm, we can add beta blockers if there are some compelling indication coming from cardiac comorbidities. Of course, initial monotherapy is still recommended in some categories, and in particular in individuals with elevated blood pressure or in individuals with frailty, symptomatic orthostatic hypotension, and age more than 85 years. If the patient is not controlled with maximally tolerated triple combination therapy, it is in the category of apparent resistant hypertension. So in this case, it should be addressed to a hypertension specialist in order to confirm the presence of true resistant hypertension, test for adherence, screen for secondary hypertension causes. Then, of course, we recommended the fourth drug in resistant hypertensive patients, spironolactone, but it's also given the results of a number of randomized, sham-controlled clinical trials on renal denervation. This task force decided to add a recommendation on renal denervation, the class 2B recommendation, in resistant hypertension specifically, so the patient could be given the option to have this kind of treatment, but also to another category of patients who are the patients who are uncontrolled with less than 3 drugs, but they are at increased cardiovascular risk. This is possible, of course, if the patient expresses a preference for this kind of treatment and after a shared decision-making process. We also recommend that this is performed only in high-volume centers. So renal denervation is now implemented in the algorithm for the treatment of resistant hypertension, together as an option, as a possible option, together with the pharmacological treatment, as you can see in this slide. Finally, we updated the recommendation about the treatment of hypertension in pregnancy, and in particular, following the results of the clinical trials published on the treatment of mild chronic hypertension. We demonstrated a benefit in terms of reduction of adverse hypertensive pregnancy outcomes. And so we propose a single threshold to start treatment, which is 140 to 90 in patients with gestational hypertension and chronic hypertension. And we recommend a single blood pressure target, which is again 140 over 90. So, and with this, I just would like to summarize the take-home messages from these guidelines. So we suggest to start drug treatment in all hypertensive patients, irrespective of age, and in patients with elevated blood pressure, depending on cardiovascular risk. We recommend a systolic blood pressure target of 120 over to 129 millimeter of mercury for most individuals, and in individuals aged more than 85 with frailty, with symptomatic hypertension, or simply who don't tolerate this intensive target, we suggest to reach the blood pressure target as low as reasonable achievable. We have novelties in lifestyle measures, and in particular on increasing potassium intake and also on adding resistant exercise training in hypertensive individuals. The drug treatment is still based on ACD plus pyro and with beta blocker only if specifically indicated. Renal denervation is now may be considered in patients with resistant or uncontrolled hypertension. And in hypertension in pregnancy, we recommend to treat also mild hypertension. Thank you for the attention.
So with that, I would like to thank our presenters for this very important session, the main session on the guidelines on elevated blood pressure and hypertension. I would like to remind you all that you can provide a 1 to 4 star evaluation for each of the presentations using the Congress mobile app. And for those of you, I really strongly encourage all of you actually, that there will be 2 other sessions following on this main session on the hypertension guidelines. At 4:15 in the room Brussels, we will have a session where you can ask questions to the guideline task force, and tomorrow at 11 o'clock in the Belgrade room, you will have the opportunity to learn more about the guidelines through clinical cases. So with that, and on behalf of my co-chair, Dr. McAvoy, and the task force represented today, I thank you so much for your attention.
Hello, good morning, everybody. Welcome to our session, Guidelines in Practice 2024 ESC Guidelines for the Management of Elevated Blood Pressure and Hypertension. It is my pleasure to chair this session. My name is Ana Abreu from University of Lisbon, and I am co-chairing with Professor Michael Olson from the University of Copenhagen. And I have the pleasure to present the first speaker, who is Dr. Rosa Maria Bruno, Paris, France. Please.
So, dear Chairman, dear colleagues, it's a real pleasure today to present one clinical case just to illustrate some practical application of the 2024 new guidelines for the management of elevated blood pressure and hypertension. This is my declaration of interest. So, let's see how we can manage a 41-year-old woman who attends your outpatient clinic for a cardiovascular risk screening. She came to visit you because she had the preeclampsia 5 years ago, and she had a cesarean delivery at the 37th weeks of gestation. So now the baby at that time was small for his gestational age, but now he's thriving and he goes very well. And so she performed regular cardiovascular screenings, but she has no family history for cardiovascular disease. She never smoked. She doesn't perform any regular physical activity. She recently measured her blood pressure at home with a validated device. She made several measurements, and she provides you with an average home blood pressure of 126/82 millimeter of mercury. And his body mass index is a bit overweight, so 26 kilogram per square meter, and the physical examination is normal. In your office, the office blood pressure is 122/86 millimeter per mercury. So, in which category we can classify this patient? And And you are aware that we have a new blood pressure classification in the 2024 guidelines. And so we have the non-elevated blood pressure, we have the elevated blood pressure, and the hypertension. So this patient, she falls both for the office blood pressure and for her home blood pressure in the elevated blood pressure category. So how we can manage this patient? So you know that if the patient has a non-elevated blood pressure, she doesn't require any particular assessment from your side. And if she has hypertension, you are supposed to start a drug treatment immediately. But if she has elevated blood pressure, the objective is to have a careful cardiovascular risk assessment in her in order to identify if she is at sufficiently high cardiovascular risk to deserve a treatment. So we provided in the new guidelines an algorithm how to manage patients with elevated blood pressure. And here is the first two steps of the algorithm. So first, we have to exclude the presence of conditions put the patient automatically at a very high cardiovascular risk, and so require drug treatment. And these conditions are established cardiovascular disease, moderate and severe chronic kidney disease, presence of organ damage, diabetes mellitus, and familiar hypercholesterolemia. So this patient has none of this condition, luckily. And so we move to the second step. In this case, it is very important to calculate risk with the score 2 or score 2 OP. So our patient is 41 years old, so clearly we will use a score 2. And we will classify the patients on the basis of her 10-year predicted cardiovascular risk in order to decide her management. Luckily enough, the patient came to the consultation with a recent blood exam. And so you can see that her serum LDL cholesterol is normal, her blood fasting glucose is normal too, and her renal function is normal too. Which means that if we have a look to the score 2 chart, and she is at the bottom of the scheme, and she is at very low risk indeed. So what shall we do in this case? In this case, it's very important to implement lifestyle measures in order to reduce blood pressure and to avoid to progress in the category of hypertension. And then it's also important to reassess risk and blood pressure periodically, so at least once a year. So let's go through the 2024 guidelines to highlight lifestyle measures and what we recommend. So you can see that lifestyle measures are a cornerstone, not only of blood pressure reduction, but also of cardiovascular risk reduction in general. So now we will go through the different points together to highlight the novelties of the new guidelines. First, these guidelines maintain the Class 1 Level A recommendation to reduce sodium intake in patients with elevated blood pressure and with hypertension. But as a novelty, we also propose a recommendation, a 2A recommendation for the increase of potassium intake. And this is the direct consequence of a few clinical trials that came up in the last year. One of these is the SSA-SS study, we're clearly demonstrating that using potassium-enriched salt substitute is effective in reducing cardiovascular events. So, how we can reduce sodium intake? So, we recommend to reduce sodium intake at least 2 grams per day or less, which is the equivalent of a teaspoon of salt per day. And, but we know that this is quite hard to achieve. Even in the clinical trials, it was hardly achieved as an objective. So a more feasible compromise should be a target between 2 and 4 grams per day of sodium. Of course, we recommend to our patients to reduce table salt. But we must acknowledge that more than 70% of the sodium we eat comes from processed and restaurant food. So the most effective intervention to reduce salt is indeed to reduce processed and restaurant foods in our diet. So how can we increase potassium intake? Potassium is found in a variety of foods, so vegetables, beans, peas, nuts, and also fruits such as bananas, etc. And it's important to notice that food processing reduces the amount of potassium in many food products. Thus, again, it's important to reduce the consumption of processed food. Of course, there's also the possibility to use potassium-enriched salt substitute, as we've seen in the clinical trials. And here you can see the recommendation we implemented in the new guidelines. And in particular, we consider that the increase in potassium intake should be considered in individuals with high daily sodium intake and without moderate to advanced chronic kidney disease. And the studies available demonstrated that this kind of intervention could be more effective in women than in men. It is important to mention that when we recommend to increase dietary potassium, especially in patients with the CKD, even mild, or with drugs that increase potassium levels, such as RAS blockers or potassium-sparing diuretics, it is important to monitor serum level of potassium. It's not the case of our patients, but it's important to remember these things, of course. So, among lifestyle measures, it is important also to mention that we should aim to a healthy weight and also implement a healthy diet. And in terms of recommendation, our guidelines recommend to follow a Mediterranean or a DASH diet. And here you can see an illustration of recommended and non-recommended foods in the DASH eating plan. And another novelty of these guidelines is the recommendation, a 1B recommendation, to restrict free sugar consumption, and in particular sugar-sweetened beverages. This is quite important both to maintain a healthy weight, but also to prevent metabolic complications. Physical activity. In terms of physical activity, we confirm the importance of aerobic exercise training, and we recommend in hypertensive patients, but also in patients with elevated blood pressure, to have at least 150 minutes per week of moderate intensity or 75 minutes per week of vigorous intensity physical activity. And any kind of physical activity could be implemented in this case, and also there is some important results of an equivalence of the classical kinds of typical of physical activity and the high-intensity interval training. And what it is novel in our guidelines is that we can associate to the aerobic exercise training some dynamic or isometric resistance training. And we give some simple indication of how we can implement this in routine clinical practice. So in terms of isometric resistant exercise training, we recommend some low to moderate intensity exercises, such as 3 sets of 1-2 minutes contraction, such as plank or wall sit. And in terms of dynamic resistant exercise training, we should recommend some large muscle group, low to moderate intensity activity, such as 2-3 sets with 10 to 15 repetitions of squat or push-ups. So these are very simple exercises that can be implemented without considering a supervised physical activity. And so this is the main change between the 2018 guidelines and the 2024 guidelines, indeed. The implementation of some resistant training exercise too. And I have no time to go into the details of physical activity and the evidence behind these novelties, but there is a joint consensus document from the European Association of Preventive Cardiology, together with the EC Council of Hypertension, that I recommend to refer to. And our recommendations also encourage to reduce alcohol intake. And of course, considering also what was recommended in previous guidelines, you can see that an upper limit is recommended to be avoided, so less than 100 grams per week of pure alcohol. But as a novelty, we recommend to avoid alcohol completely if possible, because there is no safety limit for alcohol consumption, as the big observational studies has demonstrated. And finally, I would like to remember that in order to implement lifestyle measures, a patient-centered approach is really necessary, because we have to consider also the habits, the social context of our patients in order to have an effective implementation of these measures. And also to consider that in some cases, considering a consultation with a specialist, with a nutritionist, it could be really necessary. So my take-home messages are that lifestyle measures are a cornerstone of blood pressure measurement, and they are recommended at any blood pressure level. So they are recommended in individuals with non-elevated blood pressure to prevent hypertension. They are recommended in individuals with elevated blood pressure and low risk, like our patient, to lower blood pressure. And it's important not to forget these patients, but continue to monitor them in order to check if this is really effective or not. And of course, lifestyle measures should be implemented together with pharmacological treatment in all individuals with hypertension, but also in individuals with elevated blood pressure and sufficiently high risk who already started a pharmacological treatment. So briefly, the novelties of the 2024 guidelines are a recommendation for increasing potassium intake, the recommendation for a DASH or a Mediterranean diet, and one about sugar-sweetened beverage that should be avoided, the resistance training associated with the aerobic exercise, and the no lower acceptable threshold for alcohol. Thank you for the attention.
Thank you very much, Dr. Rosa, for your excellent presentation of the cases and of the novelties. And we will ask the discussants to give some brief comments. So, Dr. Richard McManus.
Thank you very much. Thank you, Rosaria. Very nice presentation. I think that your case brings up a number of very interesting discussion points. Firstly, we have a woman who had hypertension in pregnancy and preeclampsia at relatively late in gestation, so not very severe preeclampsia, but we know that women like this will have a significantly increased cardiovascular risk, perhaps one that isn't well included in some of our risk calculation things going forward. We also have the issue of a young person for whom their lifetime risk, when they fall into this intermediate range of blood pressure, may well be high compared with someone who develops the intermediate blood pressure later in life. And then we have the interesting developments in the new guideline in terms of some of the recommendations now in terms of potassium and sodium, dietary adjustments, the isometric exercises. I thought was very interesting. Challenging, I think, for many physicians, the alcohol recommendations. But a really interesting case. And maybe to start with, could you say something about lifetime risk in a young woman such as this who's had a significant cardiovascular insult in pregnancy, and maybe how you think about that?
Absolutely. I must admit I follow my clinical practice many young this case, and in my opinion it's true that it's very complicated to correctly stratify risk, even in these people with elevated blood pressure, when the blood pressure, is not above the threshold for treatment, but again, we have an 86 of office blood pressure. We are almost there. What should we do? And if we use the score calculation, this is a 1% risk. And even if she was smoking, and even if it is impossible to go above the threshold of 5% of risk. So sometimes I think maybe we were too shy in these guidelines, because these patients really, they have a higher lifetime risk that is not completely captured by the current scores. One thing that may help, I think it's probably the use of organ damage tests, because this, I think, it could be a solution in order to understand if we are really at an increased high risk, or we can wait before treatment. So this could have been an option.
One question from the audience.
Thank you for your excellent talk about a usually forget issue of the treatment of our patients. You talk about the decrease of sweeteners beverage, but do you have any comment about the use of edulcorants?
But in terms of blood pressure, I don't think...
Cardiovascular risk. Or cardiometabolic risk.
Honestly, considering in our blood pressure guidelines, we didn't consider edulcorants specifically, and I don't think we have any association really with blood pressure. And so for this, I will recommend you just to check specific guidelines on cardiometabolic risk.
Thank you, Rosa Maria. I think the recommendations on salt reduction are really very, very important. When we see these patients in the outpatient clinic and you ask them how much sodium do you eat, they don't know what to answer. So one practical recommendation is to order a 24-hour urinary sodium excretion, which is a very inexpensive test, and then give them recommendations, as Rosa Maria said, to reduce salt and recheck urinary sodium excretion after a while. And usually this works very fine because you put them in front of numbers. Okay, I don't know if you agree with that, Rosa Maria.
I think sometimes it's not always feasible to do this in large numbers, but I think, of course, it's the only way to have a clear information. Because it's true that our patients, when you ask them, are you eating with a lot of salt, they always say, no, it's normal. But if you consider that most of the salt you ingest is from processed foods, and it's a hidden salt, and it's a 70%. I was astonished when I saw these percentages, because only 10 to 15% it's what we had with the table salt. So this is, I think, something very practical that we can say to patients, and it's something simple to implement. And I think in this elevated blood pressure category, I'm not sure we should really implement a 24-hour sodium. It could be really not feasible, in my opinion. But in hypertensive patients, it's a different thing. Of course, it could be important.
If I may add to it, of course, I totally agree, but I think the morning urinary spot where you just compare the sodium to the potassium is pretty easy. And as said, you really put them in front of the numbers, and then you have the discussion on how to reduce salt, because people just think it's normal, and then you just explain what is actually normal, and then you usually see by the next time you check it that they got the message. So I think that's very important.
And also, and I would like to insist to what you are saying, so the discussion with the patients. And often we as physicians, we don't have enough time to have this discussion. And I have the chance to work in a hypertension center in which hypertensive patients are invited to group session with a nurse, and they are and they can really have some thoughtful information about lifestyle, about sodium, and about how to measure blood pressure. Fantastic if this kind of implementation of a collaboration with other allied healthcare professionals, I think it's really so important for our hypertensive patients.
Some more questions? One question there.
Yes, please. Tanas Benedos from France. Thank you, Rosa Maria, for this presentation. I would like to ask you one question. Do you think that we have to make the same proposals for let's say, an old lady of 80 years old, especially about body weight reduction and salt restriction?
I think we never have to forget that we are doctors and we have our clinical judgment. So this is why I think it's important when we talk about the patient-centered care. I think exactly this. When we propose some intervention, we must consider the person we have in front of us. If it's useless to recommend intervention that cannot be implemented in clinical practice for any reason, considering health conditions, but also social context. So this, of course, must be discussed really with the patients, and we cannot generalize, clearly.
No, sorry, but I'm talking about especially salt restriction, because there are several studies showing inconvenience of salt restriction in older persons in terms of malnutrition. This is my main objective of my question.
Okay, no, malnutrition is of course an important topic, and when we treat old individuals, especially frail individuals, of course we must take special care. No, this is for sure true.
Thank you.
Rosemary, just sticking with the salt reduction, can you maybe give some practical advice if you have someone who is, say, developing CKD3, maybe an EGFR just below 60, and how you might be thinking about monitoring sodium, and what level, where would you start getting worried? How often would you, potassium, how often would you want to measure potassium in someone developing CKD?
So normally in our clinical practice, if an individual has no CKD, we routinely measure potassium after starting RAS blocker, for example. And now, of course, it's also important, it will become more and more important after starting an increased potassium intake, as we were saying. But it's true that in a patient with CKD, this kind of monitoring should be much more frequent. And it could be every 3 months, every 6 months, but it should be regular.
The nephrologists have like this kind of rule of thumb where they say if you have a clearance of 60, you do it every 6 months. If you have a clearance of 40, you do it every 4 months. And so if you decrease, then they just increase the amount of blood pressure measurements, kidney measurements taken. And of course, if you change medication, then they do it more regularly.
Yeah, Paolo?
Yeah, but in our experience, we find that there is a kind of holy terror of high potassium, high serum potassium. And people tend to forget that when blood sampling is done with a tourniquet, with a vacutainer, with a small needle, you usually have hemolysis, and that can raise the serum potassium up to 0.8 millimole per liter. So you have to remember that when you see 5.1, it could well be 4.3. So better check it again under better sampling conditions.
Thank you, Gianpaolo, for remarking this. And I think it's important to mention to the audience that this observation is in the guidelines now, even if it's not a class 1A recommendation, but we mention this because it's absolutely important.
Maybe we could talk a little bit more about the new exercise recommendations, particularly the anaerobic exercise. And again, so we've got a lady here, she's had a baby 5 years ago, so she has a small child, maybe she has another small child as well. What kind of exercise is going to be possible and feasible, and in your clinic, what would you be recommending that a lady like this could actually achieve?
Yeah, what I usually do is first to ask a little bit about the lifestyle, because sometimes it's easy to implement, for example, brisk walking for aerobic activity, just asking where are you working, where are you living, and trying to implement a much more physical activity which is integrated with the normal movement of the patient.
Active commuting kind of thing.
Yeah, exactly. So this, I think, it's the first thing I usually do. And then I think it's also important to understand that some patients really cannot have a structured physical activity for many reasons. That might be economical, there might be lack of time. So this is why I think it's very important what has been done this time in the guidelines, because we have a simple set of exercise that everybody can do. You don't need a personal trainer to implement this. And so it's something that really almost everybody can do on their own. And it's important to maintain the muscular mass, even with the aging. So it's something, we are recommending low to moderate exercise. So it's something that really almost everybody can do.
I think with these words, we have to go on to the next presentations. Thank you. And the next presentation is by Sophie Brouwers from Aalst in Belgium. And she will talk about pharmacologic management of elevated blood pressure and hypertension.
Thank you for the introduction. Good morning, everyone. Happy to see so many people interested in our new guidelines. And as you have all noticed, it's a guideline on elevated blood pressure and hypertension, and this is one of the main new aspects, actually. I only have declarations of payments to the department or the institution, nothing personally. And I see this lady, and she's 67 years old. She's referred to me for a cardiac checkup and for advice concerning her hypertension management, as she just had a recent TIA, and the neurologists asked for her to be seen in the hypertension clinic. When I look at her cardiovascular risk, she's hypertensive. She has a dyslipidemia, which is treated, and currently with an LDL cholesterol of 66, so not properly treated yet. She has a lab test with her from just last week, and her hemoglobin A1C is 6.2, meaning we have actually a pre-diabetic state in this lady. She has a BMI of 29.2. She's not smoking, and she never smoked. And she has a family history with her brother and her father having cardiovascular disease. So her personal history is that she suffered a recent TIA. Currently, she's under amlodipine 10 milligrams, and this dose was just increased by the GP last week because he saw that the blood pressure was not controlled at the consultation. She's taking aspirin, and she's taking rosuvastatin 20 milligrams. The first thing she tells me when I ask her, whenever she entered the room, I always ask, how are you doing, just to start with an open question, and she says, actually, my ankles have been swollen since last week. So we already know where that comes from, and it's pretty often in ladies when we increase the dose of amlodipine to 10 milligrams. The physical examination is further totally normal, nothing special. She's in a good general status. And we measure blood pressure multiple times, and we see that the blood pressure slightly varies. The first one is 142/91, and the last one is 137/87. The EKG is normal, and as I said, she has lab tests with her, which are normal, with the exception of the LDL cholesterol, not perfectly, nothing special, no kidney disease or whatsoever. How do we proceed with this patient? I know this figure is small. It is a central illustration, and I will guide you through it. It is very important in this guideline to again emphasize that we have to look at the patient and to do everything patient-centered. When we look at her blood pressure here at the consultation, and I will tell you afterwards, as most patients do in Belgium, they take their home blood pressure measurement with them. So she's actually hanging somewhere between elevated blood pressure and an almost hypertensive state under amlodipine 10 milligrams, as said, only increased to that dose since 1 week. She has similar blood pressure measurements, and as always, we check that she did it with a validated device, and she measured it with the arm measurement twice, so she did it correctly. Most GPs give this kind of documents, so they fill it in, and then we have quite good home blood pressure measurements to compare. So these are equal, office and home are equal. So what do we recommend in these guidelines? As I just said, validated and calibrated devices. Mostly people are measuring with just devices they bought somewhere, they got somewhere, but it's very important. There's a good list of it, so we have to make sure that's fine. Then we always try to use out-of-office blood pressure measurement, and this is emphasized again in our guideline, that you need to make sure that the blood pressure is confirmed, that we do not have a masked hypertension or a white coat hypertension and under or over treating the patient. And then last but not least, for atrial fibrillation, we are not there yet. So most people are, physicians are using automated devices, which is pretty easy and easy to measure then once, twice, or 3 times during the consultation. But actually for AFib, we should stick to the old measurements, way of measuring. If we then proceed in this patient, then we go down into the central illustration, and we actually see that we then get into the risk. So we are looking, and we really emphasize that whatever blood pressure increases, it's not from a certain blood pressure. The risk of cardiovascular disease increases, and it's a continuum. So actually, the elevation of the risk should be taken into account, and we really emphasize this. So as we heard already before, we look first of all if the patient has established CVD, because if that's the case, or they have moderate to severe CKD, hypertension-mediated organ damage, diabetes mellitus, or familial hypercholesterolemia, they will be classified immediately to a higher risk stratification. And so this patient has quite some risk. So we have this recent TIA, which is established CVD, there is no discussion, but she also has several other risk factors that weigh heavier on her general risk profile. So in the guidelines, we really emphasize that we should make a risk-based approach, and so as said, established is established. Whenever it's not sure and the patient doesn't have like this immediate quick line to quicker treatment and to be more aware of the situation, we really emphasize to use a risk stratification with the score 2, or if needed, the score 2 OP or the score 2 diabetes in the patients who will need it. And so this is important. If we proceed with this patient, so I will wipe out the lower part not to confuse you. So she has established CVD, and that brings the arrow straight down to the lower part of this figure, and the lower part of this figure means that we immediately need to have lifestyle measures into the setting. We just heard almost everything about it.